Mahalo. Velina meke aloha, hau'olila aloha. Greetings to all and happy Valentine's. Mahalo for returning for our second day with our Native Hawaiian Pacific Islander workshop. I'm joined by, as you know, co-chairing with me is Dr. Michael Spencer. Mike, before we get to the breakout sharing of the breakouts, lessons learned from the breakouts, you want to give a warm welcome to everyone.
Yes, thank you so much. I won't take up too much time. I just want to say good morning to everyone on this side of the planet this morning. Warm welcomes from Seattle. It looks like we got a little bit of sun popping out, so maybe it'll be a decent day over here in the Pacific Northwest, and hope that it's a beautiful day where you all are at, anywhere you may happen to be.
Mahalo. Dr. Lai, would you want to first report out from group 1 yesterday on determinants and processes?
Sure, I'd be happy to. I just want to again thank you all for joining us again on our second day, and I hope that you've all had plenty of rest, and hopefully are coming back again energized to hear about more of these talks and discussions and participate and contribute more to some of what was brought up yesterday and to what will be brought up today. So I'm here to just talk about some of the report backs from what we mentioned yesterday. So I'm just pulling up my Word document. So I was part of the Determinants and Processes breakout group. Again, one of our key questions is always to understand, what are the gaps? Are there things that we haven't yet looked at? And it was a follow-up conversation to what was brought up from the presentation yesterday. And so, one of the key things, as one discussant brought up, is like, what are the continuing or remaining gaps in research? Because people kept talking about it. And I don't think we have a total full answer, but we're trying to find what are those gaps. And so some of this, for example, someone mentioned that there's a lot of scientific and resource gaps. So one of those happens to be the importance of evaluation of upstream factors. And there's just going to be a little bit of a listing of some things. So one aspect was, we talked a lot about the individual level, but perhaps we don't always look at, perhaps maybe the neighborhood, the community level as often as necessary. And, with the talks about, the issues with sample size, there was a call out for perhaps maybe we can use a consortium to pull data from different studies and from different sources and collect data on a larger scale. This would probably be much more fruitful, especially for diseases that are rare or that are a little bit longer, like chronic disease. There's also a call for the importance of collecting information around maybe the resurgence of cultural practices that have an effect on NHPI health. So that could be examples included, like the increase in the recent surge of the indigenous languages being taught again in schools, the reinvigoration of foods and the ecosystem, the reintroduction of traditional infant care practices, and also perhaps the promotion and capturing of spiritual places in support of cultural practices. There's also someone was brought up and was discussed about the need to investigate the social cultural trauma of living in low income and resource neighborhoods. And that, we talk a lot about different upstream aspects, and something upstream in terms of at least at the individual levels, little has been looked at in evaluating early life adversity spawning from where one is raised, some of the cultural issues, and even kind of like community exposures or knowledge of historical trauma. And, a lot of our conversations talked about, obviously talked about the science and the research needs, but then it naturally, and I suppose appropriately, went into the issues of importance of trust and the necessity of community voices and collaboration with community organizations. So there was that kind of key gap about there's not enough community voices or education, and there's a call out to say that organizations can really be helpful to bridge the gap between researchers and the communities. And so trust was, again, a major issue. And we fortunately had Lonnie Park there to talk a little bit about MEC, and she brought up that, MEC was an observational core study that began many decades ago, but that it was able to increase, this is just an example, they were able to increase engagement through a lot of bidirectional feedback with communities. And that, this issue of trust and the importance of community is important because they've there's some examples that were highlighted, such as the example of sometimes logistically, there were a number of questions that were used in surveys. Then these were predetermined questions. And it was noted that they were often created or used without any input by the community. So there's a call that there really needs to be this conversation with the community about what's important to consider for these surveys. And also one of the things that was often not included was the input about what is it that's going to be shared back with the community. And so in our conversations, what often was noted was that there's this lack of, and then thus a call for it in a sense of equal footing, and a consideration how research can be more community friendly, and even at the start from the inception, so that you can include community advocates, community members to have this conversation and to see what's important, what's necessary, and especially what can be shared and what can be given back. So a lot of conversations also included issues of data sharing practices and about keeping promises, and accountability that has to come from both researchers and the community. And something that was a call to, I think in part to us here at the NIH, but to others as well, is that there's a recognition that the inclusion of community organizations takes time and takes resources to work, among community and with academics, and it takes time to build a capacity. And sometimes, there's not always a recognition that the community isn't always provided reasonable compensation or being paid to do research, unlike researchers. We talk about partnership too. But there is also a call out about the partnership with the healthcare systems, and that they need to be included as well. And that there's a number of barriers and challenges, but also a lot of potential opportunities. So that there's a call that there's importance of the healthcare system to be engaged with the community. And again, I get part of that lies in the issues of trust and some of that racism as well. And there is this history of problematic power dynamics that has existed for a lot of time. And so that there's a call to that we really need to not only create these relationships and partnerships, but we need to build these across our individual little silos. So some of these recommendations, again, there's the saying that how a lot of downstream factors can be managed by addressing upstream issues. So some things in terms of community partnership and sustainability, there's a call for advocacy of NHPI research to include and be conducted by NHPI researchers, and need to have researchers who come from the community. And there needs to be this process that would naturally build up people in the community to participate and conduct research studies, and as well as to engage and build up and train students. And there's also a need for accountability of knowledge transfer and dissemination, and overall this importance of open communication, because there still remains a lot of confusion and mistrust with a lack of input. In terms of research itself, there's the need for evaluation of upstream factors, so that even the context of it, like the sample size and importance of group efforts, and also at early life factors and culture and historical trauma, and the importance of looking at culturally relevant practices in relation to health. And there was also a call about evaluating social determinants of health from the systems science perspective, how there's the multi-level nature of factors and how there's a lot of interrelationships between them. And then there is the state that intervention studies could be built upon observational ones, but also that observational data can be used as evidence for support for policy interventions. And that concludes what I can share.
Mahalo. I guess I'll go next to do the report out for the methods breakout. But before I do that, I want to first recognize my co-moderators that joined me and helped to keep us going. That's Dr. Angela Fernandez from NIMHD, as well as Dr. Arundhati Gogineni. I am so sorry.
It's okay. It's Aruna Gogineni. It's yeah.
But mahalo for all your help.
Thank you.
I also want to recognize Dr. Karen Roberts, who helped with the note-taking for us. So much appreciated. So we had a very, very great discussion. And what I did was I organized the notes really around the challenges or gaps and the potential solutions and ways forward. So the first challenge was recruiting and enrolling Native Hawaiian and Pacific Islanders to do research studies, mainly clinical research. And there remains a mistrust towards research and researchers. So some of the solutions or way forward is promoting community engaged research approaches, such as community-based participatory research to increase participation by Native Hawaiian Pacific Islanders. The idea was shared that we could use Native Hawaiian Pacific Islander college students to help with recruitment, to help with survey interviews and the like. It was also a great way to expose our Native Hawaiian Pacific Islander students to research and encourage them to move towards a career in research. So I thought that was a nice suggestion there. There's because of the mistrust, especially for genetic research and the collection of biospecimens, and the fear of how that data might be misused or the community might be misrepresented. Out of that comes the idea that we may need to develop guidelines, protocols, and a vetting process, similar to what American Indians, Alaska Native tribes have done around genetic testing and biospecimen data collection and storage. The other challenge we identified was that there's a challenge in satisfying the expectation of NIH reviewers regarding rigor in the research approach and what would be acceptable and practical to the Native Hawaiian Pacific Islander communities. An example given was having one of the attendees talked about how they had to pivot for their R01 from a respondent-driven sampling to a cluster sampling for the inclusion of a randomized control trial. And it didn't seem like it was the original intention of their project, but it was the desire of NIH, or at least the NIH reviewers, to do so. This raises the question, are there trial designs that will address potential biases, allow for causal inferences, and be acceptable for NHPI communities, as well as the structure of their communities, such as the fact that they're close-knit with a high level of interdependence and potential, what we might call in science, cross-contamination, but just part of life, right? The other challenge is the absence of measures that capture constructs important to NHPIs. What is being measured is based on Western notions of health and well-being and Western expectations. And existing measures were not developed, tested, or normed with Native Hawaiian and Pacific Islanders, yet they are being used. Moving forward, we need to identify what is needed in a way of measures and measurement strategies that capture social and cultural factors important to Native Hawaiian Pacific Islander health. We need to identify the social and cultural constructs important to them and develop and test measures that capture them in a valid and culturally relevant manner. That is, develop our own measures. The adaptation of current measures may not be the best strategy because they were, again, developed with different populations. An example was actually given from a dementia study in which they used a validated dementia screener and found that over 60% of those screened met the criteria for significant cognitive impairment, which they very well knew was not valid. So it questioned the screener. So it's an example of how the current measures we have were not developed or normed for our populations. Therefore, they're very questionable. Many social determinants of health measures promoted for the use fail to consider the circumstances that Native Hawaiian Pacific Islanders live. For example, a great example given was household-based measures typically use the median household income, but fail to factor in the number of multi-generational households our Native Hawaiian Pacific Islander communities have, and thus erroneously inflate their SES status or their wealth. So we need to consider the circumstances and the conditions under which we're measuring these social determinants of health. The other challenge identified were those linguistic issues that we need to overcome regarding our measurement strategies. Just having English proficiency may not be enough to capture the cultural influence of language. We need measures translated into specific Native Hawaiian Pacific Islander language to ensure reliability, validity in what is being measured. Another challenge was collecting reporting of racial, ethnic data and how NHPI communities are defined in these studies, and as well as the cost and time and money to collect these data that prevent researchers, clinics, and others from collecting this data. We need to stop data disaggregation with Asian populations as it masked our actual health concerns and disparities. That just needs to stop. We need to further disaggregate NHPI data because NHPI category is made up of many groups with distinct languages, practices, aspirations, and thus health statuses. We need to go beyond capturing NHPI race and ethnicity data to also capturing their ethnic identity and affiliations to better characterize or make sense of the findings. Federal agencies could set standards required of researchers in healthcare systems and clinics in how to best capture NHPI racial and ethnic data. This is one of the challenges that was brought up, in which it's not cost efficient for a lot of clinics to have too much questions or items and so forth, but yet it doesn't allow us to adequately characterize our populations in these studies. The interpretation of Hispanic as a race and default at times eliminates many NHPI from being categorized as NHPI because of their multiracial status. Finally, we need to develop strategies and standards on how to handle mixed race data among NHPI that reflects how NHPI see themselves. Thank you very much.
Mahalo Keawe. I'm going to summarize the breakout from the cultural intervention group. I want to say that, unfortunately, we didn't have the pleasure of the presentations itself that will happen today for cultural interventions, but we had a pretty robust conversation. I want to thank Rena, Carlos, and Tu for helping to co-facilitate, as well as for the note-taking, the outstanding notes. So let me go ahead and give a summary now. So we first talked a little bit about best practices for community engagement, long-lasting partnerships, and for maintaining and developing trusting relationships for doing cultural interventions. And one of the first ones that was mentioned is one that has been pretty commonly used, especially within the healthcare field, is peer navigators or community health workers, people from the community who have lived experience, who have dealt with the same issues, who can help people with access and navigating healthcare systems, helping them through home visits, things of that nature. I think the other aspect that I think people talked about in terms of best practices was when we used those resources that were inspired by the community. So oftentimes using interventions or cultural practices that already exist within the community. People talked about the use of traditional medicine, the use of traditional foods, particularly healthy foods, as an option. There was one particular example that Joey Kinga gave that was a beautiful example of a cultural dance group that he works with his Chamorro community, where they not only engage in dance, but they use these events as a way to not just interact with the community and have fun, but also use it as an opportunity to share healthy behavior messages, as well as to collect data as part of research. We talked a little bit about best practices for upstream cultural level interventions. And, I think that one of the things that we talked about was, with these upstream factors, a lot of times those interventions are policy level interventions. If we talk about the importance of water, for all of us, particularly those of us who live in island nations, the return of water rights, the return of land, assuring people have affordable housing, and that they have access to healthy and culturally appropriate foods. These are some of the basic building blocks if you want to talk about what people need to survive. And I particularly talked about these things as, a very common occurrence among peoples who have been colonized. When people are colonized, oftentimes we aim towards genocide, and when we one of the ways in which we do that is we take away their water, we take away their land, and thus we take away their food, also their language and other aspects of culture as well. So the revitalization of these factors also becomes very, very important. We talked about looking at policies that particularly target our communities and making government aware of how those policies are hurting our communities, particularly in terms of health outcomes. We talked about looking to local experts in terms of healing and the value that they can provide for expertise in terms of developing interventions. We also talked a lot about this sense of identity, and that cultural interventions develop our sense of cultural identity, our sense of who we are, and our connection to our ancestral past. And that in and of itself is super important to the healing process and to us essentially wanting to live a healthier lifestyle in order to motivate not just our own sort of lives, but to motivate the generations to come. We talked about where the settings that these things can happen. And oftentimes we talk not just about healthcare settings, but we had one example of an intervention that occurred in Samoan churches where this community space was used to engage folks in a game, sort of a riff off The Biggest Loser. They saw a lot of people actually have weight loss through not just sort of this community support, but also through fun. A point was made that the community can help itself, that the community doesn't necessarily need other people to help them, but they do need the funding and they do need the holistic support, that they do have the knowledge that it already exists within the community. They don't want people to come in and just ask people, you know, what are the issues that the communities face, but what's actually working for them. In terms of some of the challenges that we talked about, one of the challenges that came up was this notion of isolation that many of us live, especially here on the continent. We live in communities where we do not have access to community. We don't have access to culture. We don't have access to our foods. We don't have access to even other people who share common values or share the same cultural identity. And, you know, we talked about, you know, how can we build this connectedness and perhaps even using remote methods, online methods. And we had one individual, I believe it was Paige, talk a little bit about how she, during the pandemic, took online language classes to be able to learn her language and connect with others that way. And then finally, we also talked too about the importance of the pipeline, the educational pipeline, and the disparities regarding education, and how that also is a structural factor that we can impact as well. So that was a lot. So I hope that that was a useful summary, and I'll turn the floor back to you, Gabe.
No, thank you so much, Mike and Calvi, for that report back. So I think it's very clear that there was so much conversation for each of the respective sessions, and yet you can definitely sense there was a lot of similar themes, topics that were brought up. And perhaps we'll get into a little bit more of that in more detail with the following sessions. I don't know if there's anything else that Calvi, if you wanted to add, but you know, we are certainly on time, and judging by how much people wanted to share and talk, I don't see why we shouldn't hesitate to move on to our next upcoming session. Then if that's the case, then I will pass it on to you, Aruna. Please take it away.
Thank you. Good morning and good afternoon, everyone. Thank you, Dr. Kahulokula, Dr. Lai, and Dr. Spencer for your comprehensive report back from yesterday's breakout sessions. We had several highly informative and thought-provoking sessions yesterday, and our next session will be on methodological approaches and tools for NHPI health. We have 3 distinguished experts for this session, and it's a great privilege and honor to introduce them. Our first speaker is Dr. Richard Calvin Chang, and the title of his presentation is Adapting Research Methods and Processes for NHPI Communities. Dr. Chang is a native Hawaiian attorney who co-founded and currently serves as the director of the Native Hawaiian and Pacific Islander Data Policy Lab at the UCLA Center for Health Policy Research. Dr. Chang has over a decade of experience working with NHPI communities and managing policy campaigns that address NHPI health disparities and promote data equity. He's currently working on projects that include a data curriculum for community organizations, developing accessible data tools, and supportive, inclusive, and equitable data policies. Our second speaker is Dr. Clemmer Muller, and the title of her presentation is Best Practices for Study Design and Implementation with NHPI Community Partners. Dr. Muller is an associate professor in the Elson S. Floyd College of Medicine at Washington State University. Dr. Muller has been involved in research with U.S. indigenous people since 2002, including multiple studies with Native Hawaiian and Pacific Islander partners. She has expertise in adapting study designs that respond to community needs and local contexts while preserving scientific integrity. Dr. Muller is currently a co-investigator on an NHLBI project, which is testing a home gardening program for improving cardiometabolic health of Native Hawaiian adults on Hawaiian homesteads. And she co-leads the Research Methods Core for a PO1 center. Our third session speaker is Dr. Mapuana Antonio, and the title of her presentation is Developing and Validating Culturally Appropriate Measures of Health and Resilience in Native Hawaiian Communities. Dr. Antonio is an associate professor and head of the Native Hawaiian and Indigenous Health Program at the University of Hawaii at Manoa. Her research takes a strengths-based and holistic approach by bettering the physical, mental, and spiritual health of Native Hawaiians with a focus on resilience. Dr. Antonio is the principal investigator of a NIH-funded project, which explores the role of INA and INA connectedness in Native Hawaiian health and resilience. We will now turn to our first speaker, Dr. Chang. Dr. Chang, you have the floor.
Aloha mai kako, and mahalo to the NIH and co-chairs of this workshop for inviting me to speak. I'd also like to acknowledge the elders and mentors who helped guide me, like Victor Kaiui Pang and Jane Ka'ala Pang, as well as Keon Young, who were advocating for better representation in research and data for decades. Next slide, please. My presentation will cover 3 examples that relate to ways in which research methods can be adapted to work more effectively and in partnership with NHPI communities. The first is a comparison between 2 surveys that utilize respondent-driven sampling, some of the barriers encountered and some of the ways in which those barriers can be overcome. The second goes over a framework which we borrowed from the private sector, although I think it's fair to say that it's a framework that our communities have arguably already been applying for thousands of years. The third examines indices that were used during the pandemic to allocate COVID resources, their limitations for NHPIs, and our construction of an NHPI Health Equity Index that incorporates community input to determine relevant components. Next slide, please. In 2022, the Center for Health Policy Research conducted a survey of NHPIs in California to examine behaviors and attitudes on tobacco use. An RDS model was implemented and seeds were recruited with the assistance of a community advisory board. Unfortunately, the low response rate led to a change midstream to a non-probability-based sampling design. In the end, there were a total of 1,267 respondents over a year. The second survey examines the well-being and COVID-19 impacts for NHPIs in California. It's currently underway and is being led by Dr. Brittany Mori at UCI. She partnered with our lab and brought on NHPI staff to assist with the implementation. In 1 month, 30 seeds have led to 200 responses with at least 1 chain reaching 10 waves. Next slide, please. The team implementing the first survey unfortunately lacked sufficient time to conduct formative research. The resources simply didn't allow for it. This would have provided an opportunity to build trust and relationships with community leaders that could establish buy-in, as well as help motivate seeds and networks. Unfortunately, they also didn't have the resources to hire dedicated staff that could maintain consistent contact with the community. There were also some design decisions that impacted the response rate. Only 1 respondent per physical address was allowed, which likely excluded immediate and oftentimes extended family members from networks. Next slide, please. In 2018, Dr. Veta Sanders Thomas at a NASM workshop on improving health research on small populations discussed recruitment challenges and mentioned the importance of long-lasting partnerships and that the challenge is to develop and maintain trust over time. The NHPI staff assisting Dr. Mori was able to leverage relationships that had been built over a decade of working with community organizations and to help navigate cultural protocols and expectations concerning academic researchers. Individual outreach was conducted by those with direct relationships to the community seeds before they were put in contact with a researcher. Outreach messaging emphasized the benefits of quality data for community organizations. The research plan also included regular updates to community organizations of progress being made and includes a dissemination event. The design also differed from the tobacco survey in that eligibility criteria allowed for individuals at the same address to respond. And the idea is that even members of the same household may have distinct networks due to gender roles or membership in age-specific organizations and in cultural practitioner groups. The takeaway is that RDS is viable when there are sufficient resources that are provided to allow for formative research, when research staff is diverse and includes those belonging to the communities of interest, to allow for translations when necessary, and maintaining communication with community leaders through regular updates and having a dissemination plan. Next slide, please. With regard to the second topic, I'll be discussing one of the benefits of adapting the private sector practice of iterative development. The private sector often focuses on user needs and experience. Next slide. So in our case, our lab focuses on working with community. Listed below are the first 7 recommendations of the US Digital Services Playbook. These recommendations are explicitly drawn from the private sector, and they can translate broadly to research methodologies and the development of data tools. Next slide, please. I'll briefly discuss the 4th recommendation as it applies to some of the work we've conducted with NHPI communities. Next slide. Some of the community-facing tools that are developed, sometimes for our interventions, are often set in stone from the beginning, with no ability to change or to add features or change the design once started. Instead, iterative practices insert a feedback cycle, and this includes continuous tracking and monitoring, continuously seeking feedback, incorporating that feedback, and then re-releasing the tool back to the community for another round of that cycle. This is a method that has been utilized by the CUT group in Chicago, where the city met regularly with residents at a local library to get feedback on design and features for a responsive 411 system. We also implemented a similar process in the design of our NHPI Social Determinants of Health dashboard for our AHEAD grant under OMH. Our process continuously iterated through feature and design elements, going back to the community, incorporating their feedback, and releasing it again for evaluation. Next slide, please. The takeaway is that continuous and consistent engagement with community is key to building trust and relationships. And these are the partners that made our work possible. Iterative frameworks allow for this approach to benefit both communities and researchers. Next slide, please. Last but not least, the NHPI Health Equity Index is currently being constructed at our lab, and this work is being led by Dr. Tara Becker. One of the challenges NHPIs faced during the pandemic in California was that NHPIs were disproportionately not represented in areas that were being prioritized to receive COVID resources. And that was because resources were prioritized based on a version of the Healthy Places Index that had been developed prior to the pandemic and was optimized for life expectancy at birth. The formula that was utilized to assign scores to each of the census tracts under the Healthy Places Index utilized median household income. And unfortunately for NHPIs, as Dr. Kaholokua mentioned, it's not a measure that is particularly that does a particularly good job of representing our communities. And that was the variable that had the largest coefficient in the formula that was utilized for HPI. California also didn't use the Social Vulnerability Index because it specifically contains race variables, and California has banned the use of race to allocate state resources. One of our concerns is that moving forward, indices that include a race variable could fall under, could be particularly vulnerable to legal challenges moving forward. So to address the challenges that our community was facing under the Healthy Places Index, we began constructing the NHPI Health Equity Index as something that could help supplement an index that California might choose in the future to allocate resources. Next slide, please. We constructed the index in part by seeking insight from community, and this was done in two ways. The first was to utilize the NHPI Data Policy Platform, a national policy platform that was focused on data equity that had been conducted a few months prior to the start of the construction of this index. And the second was an in-person workshop at a national convening hosted by a community-based organization, the NHPI Alliance in Washington, DC. Next slide, please. The NHPI policy platform is a product that represents the shared input and feedback from 135 NHPI leaders, representing 9 NHPI subgroups across 13 states. It identified specific needs for 9 policy domains, which are displayed on the slide. SVI and HPI components were mapped to the policy domains. Unfortunately, there were some data limitations because, for example, criminal justice statistics weren't available for our community at the census tract level in order to provide a comparison with the census tract level indices. Next slide, please. The NHPI Alliance 2023 Currents Convening was conducted last fall. And this was something that involved approximately 130 NHPI leaders and CBO staff, community-based organization staff. Attendees discussed individual, family, and community-level factors that drive health outcomes in NHPI communities. Among the key insights included age, household-based measures, the role of language, transportation, and social engagement. For example, with regards to age, one organization shared that in Orange County, California, the vaccine was being allocated for an age group that underrepresented NHPIs because we tend to have higher mortality rates and a lower average life expectancy. So our elders in our community were being left out because the age measures that were being used, unfortunately, didn't represent our communities as well. Next slide, please. Thank you very much for this opportunity to present. I would be happy to answer any questions during the appropriate time.
Thank you, Dr. Chang. Our next speaker is Dr. Clemma Muller. Dr. Muller, the floor is yours.
Thank you, and I believe I am doing my own slides, so I will be sharing my screen. But I will get started. So greetings, everybody. I'm very pleased to be here. Thank you for having me. My name is Clemma Muller. I am an epidemiologist and biostatistician from the Washington State University, and I will dive right in since we have only 10 minutes. As mentioned earlier in the introduction, thank you very much. I have 20 years of experience in providing quantitative method support for health research conducted in partnership with U.S. Indigenous communities and people. And in the past 5 to 7 years, especially, that work has expanded to really include more and more projects with Native Hawaiian and Pacific Islander partners. And my general approach, or the lens through which I kind of view doing this work, is shown here on the right. It's pretty simple. The study design phase, which is generally pre-launch, pre-funding time period, the implementation, and then the dissemination of results and findings. And to some extent, these proceed chronologically in a somewhat linear fashion, but there is quite a bit of nonlinear interaction between the 3 of them, which is why they're shown as a Venn diagram. And then the green circle represents what I think is really the kind of the meat of my talk to all of you today, which is the lens through which I try to approach this work. And the talk today really draws from the best practices that have kind of evolved for me over time. I don't pretend they're unique or that I discovered any of them, but they are things I was generally not taught explicitly in school. And so they are things that I wanted to highlight. And that reframe term at the bottom, that is an acronym for a rubric that some colleagues at Washington State University and I are in the process of developing kind of as a response to requests that we try to disseminate more broadly practical tools for applied quantitative methods research support in a CBPR context, so the community-based participatory research context, and especially geared towards an audience where the quantitative methodologist themselves is not a member of the community or the priority population of the research project. And in that context, I am not an Indigenous person. I don't have Indigenous ancestry. I moved through the world with a white racial identity. And I say that because it is relevant to some of the things I will be discussing here today. I don't have many slides, again, trying to stay in that 10-minute window, but I'm going to go through study design and implementation. I'll do it kind of quickly because I'd like to spend a little more time on the part at the end. But in the study design phase, so when we're first in the process of working with a community to come up with how we're going to do the study, I was specifically asked to think about what are the designs that tend to work well for NHPI community-based research. And really the actual designs themselves are not in general too far out of mainstream public health research as it might be taught in epidemiology or biostatistics programs today. This presentation mostly focuses more around intervention research. We do a number of randomized trials, group randomized trials, which is especially when interventions are conducted at the level of household or community. Those are pretty mainstream today. That may not have been the case maybe 10 or 15 years ago, but it is today. I think it's more about the how of the research design, and specifically, how do you respond when the views or preferences or values or even what the research will mean, as communicated to you by the community themselves, is in conflict with what I was earlier calling the gold standard, but after yesterday's discussions, which were fantastic, and thank you everyone for your presentations, I changed it to dominant because I wanted to really acknowledge that the gold standard is not an objective truth. It's not a law of physics. The gold standard is a highly subjective agreement. And in our case, the randomized controlled trial gold standard is based on a worldview that was developed predominantly by and for white cisgendered men. So I think when I'm talking about study designs that work well for NHPI community-based research, I think about community responsive solutions to community-generated requests, and especially when those requests may come into conflict with the dominant gold standard, as I mentioned. So I'll just mention a couple examples from the Pili Aina project. This is an R01. It's led by Dr. Claire Ng in the University of Hawaii, and I am the epidemiologist for it. And this study is designed to test kind of some diabetes prevention education combined with household level randomization to receive materials for gardening at home. So they receive materials for a garden box, they receive seeds, they receive education and support. And main goal of this study is to increase the access to healthy vegetable, healthy produce consumption, affordable, healthy, fresh food on Native Hawaiian homesteads, where there's currently often a lack of access to high quality, affordable, fresh food. So this is a group randomized trial. We're randomizing the households. We're randomizing them within community, and we have 7 homestead communities on Oahu that we are working with. And a couple of the community responsive design solutions that we came up with for this study are shown here on the right. So the control condition, which the dominant gold standard dictates that you want the control condition to be as inert as possible. You want it to represent the status quo. So that could be nothing. It could be usual care. It could be a waitlist control condition. That is something that is not, I would say, out of the mainstream study design approach, where you offer the experimental intervention to people assigned to the control arm after they have finished all the data collection associated with being in that control arm. My understanding, and this is what's happened frequently in other studies, is that the feedback from our communities was kind of twofold. One was, it was not really acceptable to them that the control condition represented just a wait list. They requested that everybody in the community, that the community is participating in the study, they requested that everybody in the community have the opportunity to benefit from the community's study participation. And so the way that we approached that was to implement what we call this common component. So there's community-wide programming aimed at increasing kind of opportunities to see cooking demonstrations and talk about food and food access and tasting events, and just some events designed to build community cohesion and momentum around healthy food and diet. And those are going to be offered at all 7 communities for the entire duration of their participation in the study. So that really becomes the de facto so-called control condition, even though it's really not the status quo. And so I could talk about that for a long time, but in the interests of our 10 minutes, I won't go into it further unless there's questions later. But there's a variety of approaches we can then take on the analysis end to try to accommodate that departure from the dominant gold standard. And then another idea is consistency, which in epidemiology is the principle that an intervention means exactly the same thing for everyone to whom it is applied. And that is generally interpreted as requiring the intervention itself to be delivered in the exact same way to everybody. We have to depart from that pretty frequently in the work that we do, because it's just not always appropriate or feasible to impose that parameter on community partners. And in this case, for instance, one of the areas of feedback we received was that the different communities needed to implement this community level component in different ways. They needed to implement it in a way that was appropriate and meaningful and feasible in their community, and those weren't all the same. And so, that's fine. We did that. And you can argue that this is actually a more real world pragmatic application. Does that mean I have only 5 minutes left or something? I'm not sure what that ding was. Best practices is similar. I think this is where often community-based participatory research and method support become a little harder, because once the study is launched, inevitably, we run into areas of what I call conflict. So those could be just new information or kind of best practices or problems that we've run into in the course of finally doing the study. Or it could be, other things like externally defined expectations that may not align with what's feasible or possible in the community. And so we will frequently run into this situation where there is maybe a request from our partners, our community partners, to make changes or to do things in a certain way mid-study that may cause or may already reflect an existing conflict with the dominant gold standard. And so the examples I have here on the side are from the Healthy Hearts with Asian and Pacific Islanders study. This is part of a U54 grant through NIMHD. The project lead was formerly Dr. Kaimi Sinclair, but since her untimely death 18 months ago, the project is now led by Dr. Denise Dillard at Washington State University. And this is a partially nested trial, which is a slightly less mainstream application of the group randomized trial when we randomize individuals. And the ones in the control arm are in these cohorts that kind of have group synergy, but the ones in the intervention arm are individuals that in the control arm, they're individuals with no groups associated with them. So that is a bit of a different type of design than the typical group randomized trial. And based on experiences mid-study, we had a few requests to change the design. One was to, instead of enrolling individuals and randomizing individuals into one of these arms, they wanted to accommodate groups. Maybe a couple comes in and wants to go together, or we had entire church groups of Marshallese people, communities in the 48 states who wanted to do this together, and it made no sense to randomize them separately and force them into separate groups. I would say the dominant gold standard is generally to say no, because that can be considered a pretty substantial study design change. But our approach is to start with yes, and then kind of back up from there. And so we did end up accommodating this change, and it did involve some tinkering with the study design, and there will be some analytic differences to accommodate it, but it was something we were able to honor.
Thank you, Dr. Muller. So we have, it's time to wrap up.
Was that my 10 minutes?
That is what the thing was. It was a 2-minute warning. So
okay.
Yes.
So then I will wrap up. Thank you. I forgot to start my little timer. I apologize for missing the breakout session yesterday. I had a family emergency, but this is an area that I'm very passionate about, and I would like to talk more. So if anybody's ever interested in having more discussions with this, I have many ideas for how we can do things better in our community responsive work.
Thank you so much for your interesting presentation, Dr. Muller. Our next speaker is Dr. Mapuana Antonio. The floor is yours, Dr. Antonio.
Aloha mai kako. Mahalo to NIMHD, our workshop chairs and our workshop conveners for the opportunity to present alongside my esteemed colleagues and to come together for the last couple of days to discuss Native Hawaiian and Pacific Islander health. I'm Mapuana Antonio, Associate Professor and the Specialization Head of the Native Hawaiian Indigenous Health Program at the University of Hawaii at Manoa. Today, I'm going to be presenting on developing and validating culturally appropriate measures of health and resilience in Native Hawaiian communities. Next slide. Here's a quick agenda of my presentation. And given our limited time today, there are a couple of assumptions about this presentation. First, there's a general assumption that the audience is aware of the social, cultural, and structural determinants of health that contribute to health disparities experienced by Native Hawaiians and Pacific Islanders. And then secondly, this presentation is intended to serve as a baseline or foundation for the discussion that will continue moving forward from our two-day gathering. Next. So to get started, it's important to lay a foundation for why survey research is important and should be prioritized in health research. Next. Survey methodologies in health research allow us to appropriately measure health outcomes and thus understand the severity of health disparities or the burden of health issues. One of the biggest limitations, however, is the development and validation of measures that have been standardized in other communities and populations. And as a result, these constructs may not necessarily be valid in our Native Hawaiian and Pacific Islander communities, as it's likely measuring health and health constructs from another worldview. As a result, this calls for the need to prioritize the development of scales and surveys with, for, and by Native Hawaiian and Pacific Islander communities to more adequately address health and health priorities from these worldviews. This may also help to center the lived experience and priorities of Native Hawaiians and Pacific Islanders based on survey and population data. Next. So along these lines, a survey data may provide insights on the risk and protective factors that may serve as possible mediators or moderators of health. For instance, and as described in previous sessions, while differences exist within and among Native Hawaiian and Pacific Islander communities, we see similar narratives related to the impact of colonization and ongoing historical trauma. Yet we also see narratives about the critical role of cultural values, strengths, resistance, and resilience that also contribute to our understanding of Native Hawaiian and Pacific Islander health. This is also reflected in the NIMHD Health and Health Disparities Framework as adapted by Dr. Keawe Koholokula. Measurements and tools that can better assess the social and cultural determinants of health, as well as resilience factors, may shed light on the complex interplay of variables that play a role in health and health disparities observed among Native Hawaiians and Pacific Islanders. Most importantly, and when asked properly, survey research may move health research in the direction of self-determination while also promoting health, healing, and well-being. Next slide. So now that we have a foundation about the importance of survey research, it's also important to acknowledge different approaches to research that may enhance survey research and health equity in Native Hawaiian and Pacific Islander communities. Next slide. Indigenous research methodologies acknowledge the lived experiences of Indigenous peoples as knowledge holders while promoting two-eyed seeing through the coexistence of Indigenous ways of knowing with Western ways of knowing. A decolonized research approach also considers the role of systems, structures, policies, and practices in health and health disparities. Next slide. CBPR approaches acknowledge the strength of all partners engaged in the research process and redistribute power back to community, thereby addressing power imbalances that inherently exist in research. As a result, CBPR approaches help to rectify determinants of health, particularly those that stem from oppressive policies that contribute to mistrust in research, by fostering collaborations between the various partners while establishing priorities identified by communities. So given the structural, social, and cultural determinants of health that were lightly discussed in this presentation and more formalized in previous sessions, it's critical to approach survey research by utilizing Indigenous research methodologies as well as CBPR approaches. Next slide. So this leads then to my discussion of a case example of the Ke'olo Ka'aina research project funded by Ola Hawaii, a center grant funded by NIMHD, and the Center for Pacific Innovations, Knowledge and Opportunities, a center grant funded by NIGMS. Next slide. This project would not have been possible without the various individuals, organizations, and communities who are represented on this slide here. And I therefore extend my deepest gratitude to everyone in all forms of Aina that helped to make this project possible. Next slide. This project utilizes a Native Hawaiian worldview of health, which centers our relationships. For instance, health extends to include our relationships as kanaka, or human as people, with Aina, which loosely translates to land, nature, environment, and all that nourishes us. And therefore centers this idea and the importance of this relationship between kanaka and Aina. This project also aligned with the Hawaiian proverb in saying, "He ali'i ka Aina, he kaua ke kanaka," the land is chief, mankind is its servant. Many of the health disparities that we see today among Native Hawaiians are linked to social and cultural determinants of health that stem from colonization and ongoing historical trauma that increase disconnection to Aina. And despite attempts, Native Hawaiians remain resilient, with the health of the land being a reflection of the health of the people, and the continued connection to land being a demonstration of resilience. And as such, our newly developed Aina connectedness scale is explored as a resilience mechanism of Native Hawaiian health. Next slide. As with any scale that is newly developed and validated, the Aina connectedness scale underwent processes in which our team conducted a scoping review to identify other similar measures. We also conducted qualitative methodologies to further explore concepts related to Aina and Aina connectedness with the three major themes provided here, ultimately leading to the development of the Aina connectedness scale. The scale was then administered in a comprehensive health survey that also assessed demographic data, adversities such as historical loss and land loss, and health-related priorities that were identified during the qualitative methodology process. Psychometric analyses suggested a 6-factor model, which is shown on the next slide. So this 6-factor model suggests the way in which people might experience Aina connectedness next. And with increased Aina connectedness, we also saw decreased diabetes, decreased PTSD. Next slide. The lessons learned from this project may also help to inform future research priorities by emphasizing the importance of pono processes. So this project utilized indigenized research approaches as well as CBPR approaches, and ultimately led to the development of the Aina connectedness scale that was informed and conducted with for and by Native Hawaiian communities. And as a result, really required our research team to ensure we had proper permissions and relationships to foster the success of this research. This also required the research process to center relationships and to ensure community trusts and priorities were being addressed. This thereby increased culturally responsive research approaches while also redefining health from a Native Hawaiian lens, ultimately changing the narrative of Native Hawaiian health and well-being. Next slide. This brings me to the end of my presentation. Mahalo again for the opportunity to present today and to all those who contributed to this research. I'm looking forward to our discussion section. Mahalo.
Thank you so much, Dr. Antonio. And I'll turn this over to Dr. Kiawe, who will introduce the discussants for the next part of our session.
Mahalo nui. Let me just say that I think I speak on behalf of all of us. They were excellent presentations. So mahalo nui to our speakers. I would like to now introduce, as mentioned, our two discussants that will help us elaborate on some of the ideas shared, as well as entertain some questions to explore. The first, we have Dr. Reina Mokio. She is a Native Hawaiian Samoan pediatric nephrologist at the University of Washington and Seattle Children's Hospital. She completed her medical training at Weill Cornell Medical College, pediatric residency at Northwell Health Cohen Children's Medical Center, and pediatric nephrology fellowship at the University of Washington and Seattle Children's Hospital. And I'll allow Dr. Mokiel to share a little bit more about herself and her work that she does. But right after I introduce our next discussant, Mr. Joey Kinga. And Mr. Joey Kinga is a multi-talented individual who has made significant contributions to media and entertainment industry, particularly in promoting Pacific Islander culture and representation. He is the CEO and co-founder of the Island City Media Group. He has played a pivotal role in shaping the company's vision and strategic direction. And at this time, maybe Dr. Mokiel, Mr. Kinga, you can briefly share a little bit about yourself and then go into a discussion for us and with our speakers and others. Dr. Mokiel.
Thank you, Dr. Kaholukula. As you mentioned, I'm a pediatric nephrologist here in Seattle at Seattle Children's Hospital and University of Washington. And I'm also a new researcher and learning a lot from all of you folks regarding CBPR. And it's something that I want to continue to learn and implement here with our NHPI communities in Washington. So thank you so much for having me. Then I'll let Joey go ahead.
Hafa todos hamzu, guausi Joey Kinga, sen na maguf todo I man maulik bidan mitu para I comunidad, maguf na senenti sumat now, winina etnetnum. My name is Joey Kinga, truly inspired by all the incredible work you folks have done here for our community. And I'm humbled to be a part of this esteemed group and excited to start this very important dialogue. Thank you. Sizus Masi.
Mahalo. Do we have a discussant? Maybe I can help to get us started if you would like. I realize that Dr. Mueller did not have time for her final slide for Reframe, and I am particularly interested in learning more. But perhaps maybe Dr. Mueller, you could finish that up as concise as possible as for a point of discussion that we can talk about afterwards and go from there.
I'm happy to, thank you. Yeah, so I apologize again for that. This slide really shows the general approach I take, and the cougar picture is simply that I like nice pictures of cougars and not the snarling one that my school uses for its logo, so I try to work those into my presentations. This reframe rubric really does encapsulate a lot of what I was trying to convey earlier, which is simply a process that I'm going to map to tools and resources and learning materials to help guide quantitative methodologists. And it does align with much of what I heard today and yesterday in the idea that especially somebody who's not a community member but is tasked with the quantitative research support should start by listening and paying attention and being aware and sensitive to areas of conflict with the dominant expectations or gold standard. And then they should try to come up with solutions that meet the community's needs. You know, I find a lot of the first thing I try to do is ask myself, well, why not do what the community asks? Like, what would the answer to that be? And then I try to come up with solutions that are anchored as closely as possible to the community's preference, and then present those to the community and then advocate for the community's choices, and also work to educate myself and other stakeholders and gatekeepers to try to make the process more, with a decolonization orientation. And the pushing the envelope are just kind of part of that. You know, metrics of success that came up a little bit earlier, you know, there's still a lot of gatekeeping, even in CBPR. I think as you get towards kind of the higher levels of the definitions, that power sharing really tends to fall away. So for instance, if there's a study that is mandated to try to focus on blood pressure control, well, you know, my experience, NIH will often want that to be blood pressure reduction. But in the HAPPY study, we certainly saw that many community members kind of seem to define it differently. You know, they didn't necessarily consider a reduction in blood pressure as a requisite for improved blood pressure management. And, you know, I think that those are the types of conversations that gatekeepers and funders have to be willing and ready to have, and to consider, you know, giving up power in a way that may feel uncomfortable. Another is definitions of adequate study progress. There's a lot of emphasis on that these days. And I think there are unintended consequences. I know there are unintended consequences in a kind of one size fits all approach. Even as NIH does try to be flexible, and I do try to acknowledge that, what would happen if we let a community panel determine adequate study progress? I think that often the community members may be the most well situated to decide if a study is making good progress in terms of that context. And, when I have these conversations with people, I try to encourage them to pay attention to their own reactions. And if you're reacting negatively to what I say, to just, get curious about that and ask why, and then engage in discussion. And I'll stop there. Thank you, Kiawe.
Mahalo, Dr. Mueller. I'm glad you got to get that in, because I think it does align with what other speakers were saying, really about community engagement, putting community first, community-led, but also decolonizing. I prefer using the term indigenizing, because we got to replace that with something, but indigenizing our methods and approaches. But I want to turn it back to our discussants, because I know you have questions already prepared to ask, and also we have questions from people on the chat, the Q&A as well.
I can go first. I actually had a similar or pretty much the same question, Dr. Mueller, as the one in the chat here from Dr. Gojaneni. Are there specific examples of how data analytics and or quality have been adapted to community needs relative to NHPI communities? Because you've mentioned analysis a lot and having to adapt your analytic methods based off of what's going on in the studies. And so just wanted to know your thoughts on that.
I'll answer that briefly, but then I'm sure my fellow panelists have their own answers. Some examples. Well, I think it's really backing up to scientific first principles and asking, like, what is the impact on the causal inference of whatever change was made, and then starting from there and coming up with an analytic strategy to accommodate it. So that might be interrupted time series analysis, or accounting for time varying exposures, or applying something that may be a little more complicated than you originally envisioned to accommodate just kind of the more complex data structure that developed over time. And if I can think of a specific example, I'll type it into the chat because it's one of those things that swirls around in your head as soon as somebody asks. But there are many times where we have done that, and I'll come up with some ideas for you, or some examples.
Yeah, if I can jump in, really excited to be here. And yesterday there were some jewels that were dropped. Dr. Samoa said it starts with the community. Tana said what type of research is important to our communities, especially as it relates to determinants of health. Dr. Noreen, you said and Dr. KV, you said listen to invest, to include. And we touched on a broad range of topics, from environmental topics to educational and health disparities. My question is, and I've always come back to this, is like, we cannot manage that which is not measured. So what are some best practices? Because I speak from a community standpoint, again, through the cultural groups and things of that nature, at building ethnic media. But what are some of the best practices you folks have come up with in communicating the results of the health research to the communities who may not be from academia? And so when we say building trust, right? I think Dr. Lonnie Park made mention. She said trust. How do we build trust if the language of communication isn't there? So what best practices are we doing with this incredible work to share with those in the community that they hear it's English, but it's a language they may not be familiar with?
Perhaps Dr. Antonio, Mr. Chang might want. Well, Mr. Chang, I see you unmuted yourself there.
I think it's key when authoring some of the reports that will be disseminated to the community, to make sure that there is a comprehensive review process where the various communities whose data will be reported on are part of the analysis and part of helping to draft some of the reports that go out to the community. And I think making sure that the community is a part of that process will help ensure that the language that is used is appropriate for that specific audience. And that could include things like graphic design as well, making sure that there are easily understandable and accessible graphic elements, data visualizations. What we've also found is a lot of explanatory supplemental text to help explain what it is that is being projected in the data visualization. What are some of the key takeaways that can be highlighted? And instead of simply expecting the community to be able to sit down with an academic journal article for a few hours to Google terms that they're not familiar with and to be able to pick apart from data, charts, and visualizations what the important takeaways are, to be able to summarize all of that, I think it's key to have community involved in that process.
Also, in coming from the community perspective, I always say this whenever working with whatever institute or research, is like, you're not doing research on our community, you're doing research with our community. And I need to make that very explicit whenever starting. You're not doing research on our people, you're doing research with our people. And people tend to understand it, but it just to make it explicit from the beginning.
Yes, mahalo for that point. And that is actually something I wanted to ensure that was communicated with the development of the Aina connectedness scale, is the fact that this was actually developed with, for, and by Native Hawaiian communities. And so I would like to take this opportunity to just share briefly about some of the processes that we took just to ensure, one, trust was established, but also to ensure that we had proper permissions to proceed with the study that was presented in my presentation today. So first and foremost, there's the acknowledgement that health is relational, that it's physical, mental, spiritual, and emotional, and it extends to includes our relationships with Aina. And so the Aina connectedness scale actually already starts to rethink and change this narrative around health and well-being. But it also then starts to redefine some of the measures and constructs that exist to demonstrate the way in which these relationships exist. We know this to be true in our Native Hawaiian and Pacific Islander communities, and this is just another way of developing evidence for those relationships. And so I wanted to return to your question about building trust, and I think that's so critically important. And the reframe framework that was just presented helps to demonstrate the importance of listening, of really showing up, being present, showing your authentic self. And that was actually required for this project to be a success. And so one of the slides that I had brought up was the Ke'olakaina research team and thought partners, because these were all of the different individuals, organizations, communities in which the research team received proper permission to actually proceed with some of these research processes to ensure that community was truly engaged at every single step of the process. And not just that, that also then requires then ongoing dissemination, reporting back, sharing the results as they are slowly coming in, sharing any of the themes, engaging community partners to be part of the dissemination processes, even with peer-reviewed journal articles, for example. And so within our team, you'll see that this has been disseminated in a community report back format. It's also been provided orally in written community reports, but also by engaging community partners in the research process of peer-reviewed journal articles. Now, I acknowledge we have limited time, and I could probably speak more to this topic in question, and I really appreciated the question that was presented, but I'm gonna hold the rest of my thoughts to ensure we have sufficient time to allow our other panelists to speak as well.
And I would also like to let the discussants know that there are a number of questions in the chat. If you want to draw from that for your.
Dr. Kiave, do you want me to provide some of those comments to you?
Please do.
Okay. So one is a comment or a question addressed to Dr. Clem Muller. What do you suggest for non-Indigenous researchers who want to be part of the CBPR to enter the community, especially if one is not already a part of that community? Assuming that you just didn't show up and ask a community what they needed, was it only through partnerships? How did you develop partnerships if you're not NHPI, but wish to support NHPI health studies?
Yeah, that's a great question. In my case, I was hired into a research group that involved people who are already conducting that work. And so I was kind of assigned originally as the biostatistician. And then through that, I started building my partnerships. I think probably, again, if you start by kind of listening and connecting would generally be what I would suggest. You know, if you can go to conferences or educate yourself both about what's being done in this space, but then also your own kind of position and location and the dynamics at play. And then maybe just, you know, go to places and start to have conversations with people. And then that would probably be my best suggestion for somebody who doesn't already have those kinds of connections and wants to go about getting into that type of work. But I don't necessarily have the best answer for that, however, so I do want to defer to my colleagues who identify as NHPI researchers who may have better or different suggestions.
I'd like to jump in. You know, I think identifying those in the community who are doing the work, like you know, like the Richard Changs of the world, who was doing amazing work with PIP and SoCal Pickard and all these folks, and having them kind of sign off on you, and versus just going in to the community and just trying to introduce yourself to everyone. Have somebody who is within the community who does research to kind of sign off on you and introduce you to key folks in the community. That'd be my suggestion.
Yeah, thank you. That's a great point. And I should clarify, yeah, that I was specifically thinking about, you know, first connect with the researchers who are doing work in this space. You know, the relationships with the community members really needs to probably often come through that. But there's also the possibility of, if you hear a presentation or something, just, you know, email that researcher and say, I love the work that you're doing and I would love to try to help, you know, but also just be prepared to bring a humility lens to it, you know, like, and realize that you're steeped in a certain normed kind of set of normative values, and be prepared to have those be challenged and to try to challenge them yourself as much as possible.
Thank you. Dr. Kiawe, there are a couple of other questions that have come through. Do you want me to share those?
Yes, please, if it's okay with the discussants, or, okay.
Yeah, it's addressed to everyone. What are some success stories or best practices for involving community leaders and advocates at the ground floor? And how has that influenced the quality and interpretation of generated data?
So if it's okay with the other panelists, I will go ahead and jump in. So I want to acknowledge again that our Ke'oloka'ina research team and thought partners were partnerships that took a decade almost to form and have at this stage. And so that really lends to the idea of the importance of taking the time to build relationships, going back to the previous question about coming together for community partners and forming those relationships. But I do want to acknowledge as well that there were many investigators on this study, including Auntie Ilima Holastimosa, Dr. Samantha Keaulana Scott, Lachey Kili'u Holokai, as well as various community members who actually played a very critical role in the success of this project. And so identifying the Ke'oloka'ina research team and thought partners at the forefront is a demonstration of the way we can start to center our community partners as equal partners in the research process. And so for thinking about the Pono processes that was suggested at the end, that also alludes to the idea of the way in which community knowledge holders are equal in the research process and therefore plays an important role in the success of many of our research projects. Many of the grassroots initiatives actually contribute to much of the knowledge that we see in research and community-based participatory research. And so when we come with that more equitable lens, I think that helps to really uplift the work that's already happening in community to ensure the success of our research as well. And so I'll turn it over because I did see a couple of other people unmuting themselves.
I've heard community advisory boards being cited as a common example of how to engage, but I don't think that we can, I don't think we should overestimate its importance because it's not a substitute for authentic relationship building. And I think there's a danger in only discussing relationship building in the context of research projects, when the pandemic hit, the time to build relationships was not in the middle of an emergency, but to have established them years prior. And I think what people underestimate in importance is just simply showing up to community events, being open and willing to learn about other cultures, their protocols, to be open to a different kind of worldview where families and communities are prioritized over individuals in terms of their values and principles, and being able to incorporate that and share those values through participation in activities that a lot of community organizations host. I think that certainly goes a long way towards building relationships. And then once there is a research idea, to make sure that the community partners you like to work with are brought in when the idea is being drafted before the proposal is submitted, as opposed to being brought on afterwards as an afterthought, that they kind of have to fit their round peg into the square hole to fit the researcher's priorities. So that would be my recommendation.
Mahalo, Mr. Chang. I want to turn it back to the discussants. If you have any questions, you want to open up for additional discussion before we go back to the Q&A.
Yeah, I actually had a follow-up question to all of that was mentioned. I think that everything that you guys are doing sounds, completely appropriate and pono and like with and for and by the community. But I think one question that I feel like keeps coming up, or one theme that keeps coming up is like data and like having like bigger sample sizes of our people, and that new cohort study that is being done, for Asian Americans and Native Hawaiian Pacific Islanders keeps coming up. And so I'm just wondering how you guys envision like incorporating like true CBPR principles, incorporating the community from the beginning of these like larger cohort studies. How do you, in your mind, what would be like the ideal way to do all of this?
I can get us going. I mean, with any study, I think what's been pointed out by our speakers here is that there has to start with engagement before even the funding occurs, right? Before even the funding occurs, before you sit down and start writing the grant, there has to be involvement, engagement, and community input, community evaluating what we're proposing every step of the way. So I don't know how to best answer that question in that context, other than it would be the same for any study. I think one of our Maori colleagues also commented, by us, for us, and with us. So, no kako, na kako, yamako, or kokako, however we want to phrase it, nothing without us. I think that was really pointed out by all our speakers at every step of the way. And I really like Mr. Chang's iterative approach, right, in which it can change. And Dr. Mueller, you also commented on that as well, that sometimes you have to adjust midstream. And traditionally in dominant research environments, that would be frowned upon because you're deviating from protocols, right? You're deviating from what you originally proposed. But as mentioned earlier, it reflects real world situations. Certainly the longitudinal study, most longitudinal studies, because there has been certainly others, other cohort studies done with other populations. We know that over time they adjust their measures, they add new measures as they learn more, as more questions come up. So I think the models and examples shared by our speakers really illustrate some of the preferred and best practices of our communities. And I think the theme here is be flexible, and that we can balance the scientific rigor with what is really needed for our communities so that we get the information, the knowledge we need to make real change in real world and not controlled conditions, right? But I'll stop there. I think I said enough as a moderator, and I'll open it back up to all of you. I don't know if Dr. Antonio, Mr. Chang, or Dr. Mueller want to elaborate on that and add more to the idea of a cohort study that I think is also a question coming up in the chat as well.
And if I could just tag in on that, you know, the part of the simple, some of the simple questions that may come up in working with the community is who owns the data, right? So how do we address that? How do we present that, and what are some best practices? And, you know, obviously the answer we want to hear is we all do. But are there some cases where researchers don't share that? I don't know. I'd be interested to hear that.
That's a great question.
I'm sorry, if the question was when researchers don't share you mean like the data sharing requirements that NIH has, or did you mean something else?
Not by NHS specifically, but in doing research with the community, some community members may go, okay, well, you've collected all this data. Who owns it? Are we able to access it and use it the way we feel necessary, or is this all this just for the researcher or the institute?
I know that, and I think my answer to that goes back to also what Kiave, I think it was Kiave who said about how the relationship building has to start before you even, you know, write the research study. And data use agreements, or, you know, is a common document that we use to answer those questions, try to answer those questions ahead of time. But again, the default, I think it's very important that the default is always to community ownership and or individual ownership, whatever is most appropriate for that context. It does run into challenges with an increasing emphasis on more open data sharing at National Institutes of Health, which, you know, I appreciate the rationale for wanting to do that. And then I also appreciate why that poses, you know, many potential problems, many real problems and concerns for the communities that many of us work with or are members of. And so I don't have an answer to that one, but it's a real problem, especially in things with like biospecimens is obviously a big area. And I do see a lot of blind spots at NIH, and this probably has to do with that longitudinal data question. Not just at NIH, I'm kind of using NIH as a fill-in term for the larger system. But, you know, things like collecting blood samples. So it's not about just who owns them, but sometimes it's about what happens to the unused sample. And just understanding from the beginning that those are important things to think about and talk about, and then often advocate back to the funder or others, you know, in favor of the community solutions is really important. I don't know if that exactly answers your question, but there's a lot of complexity and context in all of that. I realize it's not an easy answer.
There's a question that Dr. Das has posed. Let me see if I can get
before we get that, there's some chats, there's some questions coming to me privately or in direct message that others can't see, but just before that one, we'll get to Dr. Das's one, because I think this is a interesting question actually, and this is for you, Mr. Chang. NHPI populations are settling in new communities. Some of them are more dispersed than the concentrated communities in Hawaii or LA. Are the zip code or census tract level social determinants of health and equity measures still meaningful measures for assessing the context for our NHPI groups that are establishing themselves in new spaces? If not, do you have recommendations for assessing neighborhood and environmental level factors for more dispersed communities?
So I know I'm going to sound like a broken record, but community engagement is key to answering that question. So organizations like the one I operate under CHPR runs a California Health Interview Survey, and sometimes they contract with third parties to conduct surveys. And these third-party contractors will be willing to focus on particular areas at the sub-county level based on recommendations from our survey methodologists. So it's possible to ask for oversamples to be drawn from NHPI cultural enclaves, but those need to be identified in conjunction with community input. You can't just create an arbitrary population threshold and say, because there's a certain percentage of NHPIs within this cluster of census tracts, that there's an enclave in this area. Working with community to identify those enclaves can help those who undertake these surveys to oversample communities in those specific geographic areas at the sub-county level. But again, like that will necessarily involve community input. But even in the continent, our communities tend to cluster around each other. Tongans maybe around airports, maybe some communities around military bases. Native Hawaiians tend to be a bit more spread out, but a lot of them do tend to reside in these smaller areas where you can start to see at the census tract level some of those SDOH determinants.
Mahalo for that response. All right. Unless our other speakers have anything to add, or anyone else, our discussants to that one, then maybe we can entertain Dr. Doss's question.
Sure. Do you want me to go forward with the question?
I can read it. I can read it for you.
Okay.
Can you talk about best strategies for effective communication of scientific and research findings to NHPI communities, such as using your media group? And this is really directed to you to discuss it, Mr. Kinga, as an expert in the media and reaching out. I know in our discussions earlier for pre-meeting, I got excited about a lot of the ideas you had and comments you made about we're not reaching our communities because our communities are different. We have different ways of engaging and coming together, and we have to create unique ways. So yeah. So I'll leave it to you to answer that question.
Oh, and thank you for the question. First of all, let me say that, I think everyone on this panel and everyone on these workshops are very, very obviously very important to our community, not only because of the work that you do for our community, but the example that you give to the younger NHPI Pacifica kids, Pacifica generations in the future. And that's really what we strive to do at Island City Media Group. There's no BET. There's no ethnic media group for our Pacifica people. There's no Univision, there's no Telemundo, there's no BET. So what Island City Media Group really started off as was our way to fill the gap that was needed. It was our, community service comes in many different forms, right? So this was our way of filling the gap. And so the question is, talk about your best strategies for effective communication, scientific and research findings to NHPI community. I will say that what I do is absolutely exciting and fun. And I get the best part of this whole cycle. You folks do a lot of the heavy lifting, and I get to take that information and share it with our community and do that through our radio station. Where we highlight a lot of the Pacifica artists. You guys know our people are some of the most talented people in the world. So I get to build these incredible relationships with these international singers from Aotearoa, from Hawaii, from Samoa, from Guam. They come into the studio, and that's the carrot at the end of the stick. And we get to fill and share all this incredible work and information that you folks do on air while they're waiting to hear some incredible music. So that's some of the things we do. Each of our shows on our station, which runs 24/7, is hosted by a Pacifica host. And they all understand, whether it's weekly or if there's a new PSA, they all understand to do live reads and share some of the important work that you folks do. So that's it. I get the fun part, you guys. You guys do the hard work. And so thank you for all you do. I hope
we definitely need the creative folks like you to help translate what we're saying in the sciences to what everyone else talks in the real world, right? It makes sense for everyone. I just wanted to add, what you're saying, and I think this goes back to what Dr. Doss is also wanting to get at is, as Pacifica people, we interact face to face. That the best way for us to communicate is being present, physically there. Because for many of our people, it's about inferring the intent or knowing the intent of the researcher and getting a feel. And that can only happen not over Zoom, right? It happens in the room with them. And I know for many of us in Hawaii, we do what we call report to the communities after our projects, or ho'ike. And in Hawaiian, that means to demonstrate your proficiency in something, right? And we'll invite all of the participants, their families, all the community leaders and partners, and we'll have what we call like a paina or luau, what you folks might be familiar with, a festivity around it. But we also use that as an opportunity to disseminate the information. Again, ikealo, akealo, face to face, but also in a manner that is taking the scientific, the statistical findings and turning that into really practical ways and solutions. So those are some examples I just wanted to share that we do, and it's much appreciated. In fact, it's so much appreciated that, you know, we work, and I think goes back to also the intent of this question. We operate by word of mouth, the coconut wireless, we call it, right? And that is the best way for us to get momentum and recruitment going, is the coconut wireless, but that can only happen ikealo, ekealo. But I'll also open this up to others, because I know Dr. Antonio, Dr. Mueller, as well as you, Dr. Mokiao, and Mr. Chang, definitely all are engaging communities in different ways and have been in situations, whether with patients from our communities or participants, in communicating information in a way that they can actually take and apply in their daily lives and make sense of it. Well, I guess we were quite clear the first time and nothing needs to be added, so we can move on to the next discussants. Do we have any other questions you're burning to ask there?
From my perspective, there's so many great questions in the Q&A I'm looking at, and then also in the chat. So I want to make sure we get to those too, if that's okay, unless Joey, you had a question.
No, absolutely. Let's move on.
Let's see, I see one here. I'm sorry if I'm not going in order. It says, as Pacific Islander researchers, have you experienced challenges with the communities you work with? And if so, can you please share an experience? How do you address these challenges and work with the communities to create solutions? Great question.
Is that open to everyone on here? Or we just jump in?
I think anybody, yeah.
It's open to everyone, yeah.
You know, the theme of building trust in our communities was prevalent yesterday. And so, you know, I'm going to go back to what I know, and that is being a cultural practitioner for over 3 decades, and not only seeing, you know, kids start to have kids, and now 4th generation, I'm aging myself here, but building that trust with them, and also putting in their mind, like, we can do things outside of, outside of, you know, working in the military. Now, my father's in the military, so please don't come at me. But like, we can do work, we can be researchers, and these questions that we're asking is not intrusive, because they're coming from folks that look like you, that you trust. So that's some of our best practices in working with researchers, is already having that credible platform, you know, that our community works with.
One of the challenges that I've encountered working with community organizations has been the fact that research projects are often conducted in conjunction with the grassroots work that they're doing on the ground. And so the reason that these organizations exist in the first place is to serve the folks on the ground. And oftentimes are under-resourced. There really isn't as much investment from funders as there really ought to be, given our community's challenges. And without that capacity, it also limits the capacity to be able to work with researchers as well. So one of the ways that we've tried to address that is to make sure that we write into grants additional funding for the community organizations that can assist with whatever research project we might have, but to also keep an eye on how the research that gets done could be communicated to potential funders, and in that term, help with the sustainability of these organizations. So I think that's definitely one of the strongest challenges that we've had to face, that we continue to do so. So making sure that those resources are available to continue supporting the work that organizations are doing on the ground, I think is essential.
To kind of jump off of that remark, I wanted to acknowledge that sometimes there's more structural issues that play a role. So for example, a lot of times relationships might be in place, but the timeline of the research or even forming relationships to ensure that the research is successful doesn't necessarily align with the timeline of funding, for example. And so not necessarily challenges with the partnerships per se, but more so some of the structural issues that might arise during the research process that can then influence and create nuances for these relationships that already exist. One of the things that was also mentioned was the importance of food and gathering in person. And sometimes there's limitations for the way in which funding can be spent that doesn't necessarily align or honor some of these priorities or values in the report back process. And so I think some of these concerns can actually raise some tension in relationships that exist because of the desire to want to honor food, for example, at the table, to report back on Aina, which is in essence talking about nourishing our bodies and nourishing ourselves through these connections, and having to ensure our community partners and researchers who are engaged in this process are aware of these timelines and some of these budget constraints. And I think that's more so some of the challenges that has come up in our research work, rather than challenges within and between researchers and community partners. But I'll turn it over to Dr. Mueller in case she had something additional to add.
Oh, thank you. I fully agree with what you said. And one example I have of that I've experienced too is you know, NIH has a lot of initiatives and efforts and statements to try to become more accommodating for that reality that this kind of work takes longer, but there are areas where that doesn't always align in practice. And one would be maybe the study section reviews. When you know, realistically, we still have to seem to make promises to enroll samples and have timelines, you know, that look more like other types of studies in order to compete for funding, but then we're held to those afterwards, and we have to then prioritize that, you know, over elevating maybe community leadership. And so that's one example that I've experienced frequently. I also just wanted to address Lucy's question in the Q&A quickly. It was about how do we get non-researchers, how do we get culturally appropriate research done? And I don't have the answer to that, except I wanted to mention that, you know, I don't think it's necessarily the job of the people, you know, the community partners who are trying to move this research forward or engage with this research to get it done in a culturally appropriate way. I think it's really the responsibility of the gatekeepers to listen and respond and change how they do things. So I'll stop talking because I want to let other people talk for the last few minutes, but that was just a perspective I wanted to share. And I'd be happy to talk more about that with anybody afterwards.
Mahalo. We have 2 minutes left. And what I would like to do, because there is another question in our chat, if our discussants will allow me, from Dr. Tapara, and I think it's a very relevant question, especially for well, of course, Native Hawaiian Pacific Islanders, because we have undergone this acculturation process. We acculturate in different ways. We have different acculturation out of necessity sometimes, depending on geography, where we end up in the diaspora. So the question is to you, Dr. Antonio, for your work on Aina connectedness. And again, praising your work, your great work you're doing. But the question is, do you feel the scale reflects that part of our lahui or our people who have disengaged due to centuries of colonization, or are we more connected than we know?
Mahalo for the opportunity to respond to this question. Mahalo, Dr. Tapara, for this question. I'm going to do my best to respond within the minute that we have remaining, but part of this work in Aina connectedness was also acknowledging some of the larger structural, social, cultural determinants of health associated with that. And so Dr. Samantha Keaulana-Scott actually is exploring historical loss and some of the associated outcomes related to that, because in order to understand the way in which a factor might serve as resilience, it's also important to understand some of these adversities that contribute to the health and health disparities that exist. And so this really took a cockle effort and approach to understand how some of these larger structural determinants of health also impact Aina connectedness. So some of the future directions that we're also looking at is aina connectedness within the Pai'aina, or within the islands of Hawaii, but also to those who might have experienced migration to the continent, for example, and the way in which we can continue to foster aina connectedness through these values that might exist, through the practices that come with that, through these ways of knowing that foster that, to uplift that identity piece that also comes with that. And so I think this is really just the start, hopefully, of the long-term work of understanding the way in which all of these factors come together to foster health and well-being. And this hopefully is just a start to seeing that transformation of that. And not just that, but the way in which we start to even think about health and well-being. And so with that, I know we are out of time, so I'm going to turn it back over.
And I think it's a nice way to end by saying what you highlighted. There is a lot of diversity or things to consider, because we are a diverse group. Within our diverse groups, there's even further diversity because of acculturation, the need to assimilate sometimes out of necessity or survival, especially generational differences in that. I know we see that. So there's so much to consider when we're looking, especially around measuring constructs that are important to our people in ways that capture the evolution or the re-evolution or the regaining of our cultural identities and practices again into society. But anyway, mahalo to all of you. Excellent talk, excellent discussants. Couldn't ask for more. It was awesome. Thank you so much. I turn it back over to Dr. Lai.
Thank you, Kiawe. Thank you so much for all of you who participated in this. And thank you just listening to the conversation and seeing things on the chat as well as the Q&A. I actually wish this session could go on longer. But we do need a break, mentally and biologically. And so I'm going to just ask that we resume, take our break right now. And I know we're just a tiny bit over, but let's see if we can try to get back here at 2:55 p.m. Eastern, 9:55 Hawaii time. Thank you again. Hello all, I just want to welcome you back, and hopefully you've had a chance to refresh and a little bit from the brief respite. But I do want to ask that we all resume, and we can start with our fourth and final session on cultural interventions. And I will now pass this on to Carlos. Carlos, please take it away.
Thank you, Gabe. Aloha, everyone. My name is Carlos Garrido, and I'm a program officer in the Division of Integrative Biological and Behavioral Sciences here at NIMHD. I'm a member of the coordinating committee for this workshop and the moderator of the Cultural Interventions thematic session. I'm pleased to introduce three great speakers today that will leverage their scientific expertise to enable a greater understanding of cultural interventions to improve Native Hawaiian and Pacific Islander health. The first speaker is Dr. Rachel Novotny, Professor and Chair of the Nutrition Sciences Graduate Programs at the University of Hawaii at Manoa. Dr. Novotny's nutrition research has led her to work extensively in the international arena, including countries like Costa Rica, Peru, Indonesia, the Republic of Palau, and the Commonwealth of Northern Mariana Islands. Dr. Novotny examines maternal and child nutrition and health in remote regions of the world and among culturally diverse populations, studying lifestyle patterns in diverse settings and populations that inform strategies to improve nutrition and health. The second speaker is Dr. Scott K. Okamoto, professor in the population sciences in the Pacific program at the University of Hawaii Cancer Center. Dr. Okamoto also holds an adjunct professorships at the University of Hawaii's John A. Burns School of Medicine and Hawaii Pacific University. Dr. Okamoto's research focuses on the social determinants of health and on developing evidence-based prevention interventions with indigenous and/or underserved communities. He currently serves as the principal investigator on an NIH-funded e-cigarette vaping prevention study for NHPI youth on Hawaii Islands. He is also a co-investigator on NIH-funded interventional studies focused on alcohol use disorders and vaping cannabis co-use among Native Hawaiians and Pacific Islanders. Last but certainly not least is Dr. Marjorie K. Lamimu Mau, a professor and Myron P. Thompson Endowed Chair of Native Hawaiian Health Research at the John A. Burns School of Medicine at the University of Hawaii. Contextual perspective to our understanding of NHPI health and how lessons learned bring insightful perspectives to moving NHPI health research and equity to contemporary issues we are facing today. Dr. Mao is actively funded by multiple NIH-funded studies and has served in multiple research roles to design, implement, analyze, publish, and translate intervention trials with and for NHPI-engaged communities. She continues to strongly advocate and work with NHPI organization communities and institutions to promote holistic health and ancestral knowledge system. I will now turn it over to Dr. Rachel Novotny, who will present on Children's Healthy Living Center of Excellence in the U.S.-affiliated Pacific. Dr. Novotny, please take it away.
Thank you very much. It's an honor to be here with all of you on behalf of the Children's Healthy Living, or CHILL Partnership and Center of Excellence. Our partnership is based at the land-grant colleges of the U.S. affiliated Pacific. This includes Hawaii, Alaska, American Samoa, Commonwealth of the Northern Marianas, Guam, Palau, Marshall Islands, and the 4 states of the Federated States of Micronesia, Yap, Chuuk, Pohnpei, and Koshrai. And we came together to have a louder voice with a goal to improve nutrition and health with guiding principles of remembering our ancestors, respecting nature, and focusing on children as the future. These CHILL jurisdictions are not part of the U.S. National Health and Nutrition Examination Survey Data Collection, or NHANES. And so CHILL provides prevalence and descriptive data on nutrition and health for program and policy planning. And we also conducted a multi-level, multi-component trial in the 5 jurisdictions that are in blue. The aim is to prevent young child obesity and improve health among communities that are predominantly indigenous to their jurisdiction. And that trial has been followed up after 4 years and now with food system dynamics activities. So the timeline of CHILL is shown here, although foundational relationships were built over several decades. Funding is from the USDA Competitive Grants Program in a series of 3 grants. Grant 1 began with community meetings to develop strategies for intervention, followed by baseline and prevalence survey, and then at the 2-year intervention in 5 jurisdictions, then follow-up measures, then delayed optimized intervention in control communities. And then in Grant 2, we completed 4 years later a follow-up to that intervention trial. And now in Grant 3, we're working with new community gatherings to examine food systems dynamics and developing food simulation modeling, building off of the previous work, as you'll see. So the average prevalence of measured overweight plus obesity in the 2 to 8-year-old children across the 11 jurisdictions was 29%, with substantial variability, as you can see here. The CHILL trial intervention template was developed with communities using a multi-level and multi-component approach based on the social ecologic model and a positive deviance approach of identifying and supporting healthy indigenous activities and role models who are doing those activities and who are provided with resources to do more and collaborate with others. The study measures shown here were at jurisdiction, community, household, and child levels, and included measured and standardized anthropometry, acanthosis nigricans, sleep, screen time, accelerometry, and food intake and physical activity logs. 27 communities were selected for the trial within the 5 jurisdictions, prioritizing communities with more indigenous residents. 18 communities were matched and randomized to intervention and control, and the remaining 9 communities as temporal comparisons. More than 5,000 children were measured in intervention and control communities who are predominantly indigenous to their jurisdiction. The intervention activities were developed with communities and informed by the successes from peer-reviewed literature. The final intervention template included activities the community found important and doable to improve the selected target behaviors around healthy eating and activity. So the series of 19 activities were in the domains of policy, environment, messaging, and capacity building, with a predominance in the environmental change area. Each jurisdiction interpreted the activities and behaviors in their own way. This one's shown the Hawaii version of some of the materials. Right, delay here. And the trial showed a 3.9% decrease in community prevalence of overweight and obesity among children in intervention communities here in blue, as compared to the control communities in orange over the 2-year period of the intervention. And the level was actually, the effect was increased, and the difference became greater over 4 years after the intervention was over, with no involvement from the researchers beyond the community. Still, the target behaviors showed marginal improvements. And so now we're back working with communities. So we saw an overall effect, but in measuring individual behaviors, we could not see a lot of change. We did see some, but we're now going back and working in group model building to understand combinations of factors and dynamics of the intervention influencing healthy eating and health. These pictures illustrate the American Samoa group model building activities and the resulting causal loop diagram from this work. So we are now using variables identified from 5 jurisdiction causal loop diagrams and group model building activities, and are working on building simulation models of resiliency. Our resiliency framework was built from the high-level panel of experts on food security and nutrition in blue, to which we've added in orange the data that are available from CHIL to begin this modeling with, and in yellow some data that we hope to continue to gather to add to the modeling going forward. So we have learned the value of partnering with Indigenous and other community partners through discussion of shared values, meaning of health, and strategies that work that actually began in the late 80s. We learned to identify individuals doing effective strategies, especially Indigenous ones, and to fund them to do more, to expand, and to partner more, to build coalitions. We've provided capacity building and degree training, and built infrastructure for doing research. In my view, integrated funding for research, training, community partnership, and infrastructure development is needed for impactful and sustainable results. And increasing funding cooperation across the federal institutes could further enhance impact and sustainability. Thank you.
Thank you very much, Dr. Novotny, for such an insightful presentation. Next up is going to be Dr. Scott K. Okamoto, whose title of his talk is An Overview of Culturally Focused Interventions for Native Hawaiians and Pacific Islanders. The floor is yours, Dr. Okamoto.
Good morning, everyone. Well, good morning from Hawaii, everyone. And thank you, mahalo to NIMHD for hosting this workshop, and to our outstanding co-chairs for, so far a day and a half of great presentations. So thank you for that. Yeah, I'll get started. So, during the height of the COVID-19 pandemic, like so many of my colleagues, our team had to halt all of our research activities. And so at that time, I charged my research team to really set, really kind of figure out what is the state of the science in prevention for Native Hawaiians based on the published literature, because we couldn't collect any of our data at that time. So what our team did was use PRISMA procedures to examine the prevention literature for Native Hawaiians published between 2015 and 2020. And we picked this time period because we wanted it to align with an increase in federal efforts to encourage research for Native Hawaiians. And specifically, I'm referring to the FOA intervention research to improve Native American health, or ARENA, in which Native Hawaiians were included as part of that call. I also know that NIMHD also had a NHPI focused supplement at that same time period. So we wanted to see, were some of these efforts effective in encouraging research, prevention research focused on Native Hawaiians. It also served as an update to prior systematic reviews that our team and others have focused on Native Hawaiian, that were focused on Native Hawaiian interventions. So this review and several of the reviews before this one were really the outgrowth, I feel, this is my opinion, of one seminal article published in 2008 by Dr. Noreen Mokuau, who we heard from yesterday, and her colleagues. What they did was they analyzed 23 social work journals over a 9-year time period, so from 1995 to 2004. And they found that only 0.64 of the articles in that time span, of the 5,000 articles they reviewed, were focused on Native Hawaiians or Pacific Islanders. So 0.64, not 6.4, 0.64. So, I mean, that's just unacceptable, right? And I think that I felt one of the things that we wanted to see over time since that seminal review is have things progressed? How have they progressed, right? So these were our findings. So we identified 14 peer-reviewed articles conducted by 9 different research teams, several of which are on this call. And the majority of these studies focused on program development or efficacy effectiveness trials. So really looking at that earlier to mid translational research part of the spectrum. Oops, sorry. Trying to move. Okay. There was only one study focused on implementation. So the later phases of the translational research spectrum weren't really focused on at this point. And I think it just speaks to where we're at in the science. All but one study took place in Hawaii, but notably close to 80% were supported by NIH funding, specifically NIMHD, NCI, and NIDA. So what we concluded was that, 14 peer-reviewed articles isn't great, but I feel better than when Dr. Mokuau and her colleagues published their initial article. But so more research is indicated for sure, but the findings do suggest that federal efforts to increase prevention research for Native Hawaiians have had some impact, but we still need more research in the areas of dissemination and implementation research for Native Hawaiians, and really like research on Native Hawaiian populations outside of Hawaii, because the majority of those studies took place in Hawaii. So on this slide, what I did here was mapped several established and emerging Hawaiian-focused interventions based on where they lay on this continuum that we published in 2014 that looked at adaptation approaches to culturally grounded approaches to prevention. And so what we see here is that in the earlier years, so in the mid-90s, we had more of a focus on interventions that were more on the non-adapted or surface structure adaptation area. So here I'm referring to Dr. Kamioka's adaptation of strengthening families program. But what we're seeing more currently in more of the newer literature is a focus more on deep structural cultural adaptations and culturally grounded approaches, several of which we've heard of already, the Piliaina program that we heard earlier today, as well as yesterday referenced. That's Claire Ng's new R01 study. There's somebody else on the continent, Lexi Jackson, who is doing an adaptation of a caregiving program, Oamo Kuleana. and working with a Native Hawaiian homestead here to work on that adaptation. And interestingly enough, that adaptation is really evolving into something that's completely different from the original intervention, which is something I think we could be interesting to talk about after my presentation and in the Q&A. And then there's culturally grounded approaches, which are really looking at what's happening already in the community and using that knowledge to build interventions from the ground up, right? So there is Dr. Kaholokula's Kahola study. One of the interventions that we talk about in this 2014 article is Ho'onopono, which is our substance use prevention curriculum, which I'm going to talk a little bit about next. So Ho'onopono is a community university partnership. It was initiated by the County of Hawaii Office of the Prosecuting Attorney. So this is really interesting. So this harkens back to what Dr. Antonio talked about in terms of timing. So I received a K01 award. And so at that time I had funding, but not really a concrete plan as to what the study was going to look like. I mean, I had enough, I knew enough about it that I could get the funding, but I didn't have all the details worked out. And serendipitously, someone from the County of Hawaii Office of the Prosecuting Attorney on Hawaii Island reached out to me and said, we're developing this comprehensive strategic plan in which a substance use prevention is a part of. We need an intervention. What do you know about existing interventions that we can build into our strategic plan? And we talked for a long time about different interventions and what their strengths and limitations are. And ultimately, he's like, none of those are going to work. We need something that's focused on Native Hawaiians, Pacific Islanders, and specifically on Hawaii Island. So I said, well, we're going to have to develop it then. And so that started a collaboration. This collaboration evolved between the Department of Education on Hawaii Island, the Prosecuting Attorney's Office, and UH, and at the time HPU, where I was originally located. And we've developed, evaluated, and adapted this curriculum over 5 consecutive NIDA-funded grants from 2006 to now. I heard the bell, so I'm just gonna try to go through some of these really quickly. It's a 9-lesson video-enhanced curriculum focused on resistance strategies. We aligned that with the Hawaii Content and Performance Standards for Health. It was implemented by teachers in the classroom, and we monitored fidelity through an online discussion board and virtual classroom. We conducted an efficacy trial in the academic years 2016 to 2017 and 2017 to 2018 using a dynamic waitlisted control group design. And some of our key findings were that we found promising results for e-cigarette and cigarette use and hard drug use, leading us to conclude that the strongest effects of the intervention may be on curbing the use of emerging or novel substances. So lessons learned, we were asked to do lessons learned for each of our presentations. And so some of the lessons that I've learned over the years is that really community is in the driver's seat, right? So we all have our expertise, but we have to take lead and direction from what the community wants and what the community needs. In addition to that, the community wants tangible outcomes. They're not interested in knowledge for knowledge's sake, validating models or theories, things that academics are really interested in. They need something. They want an intervention. They want something, some kind of manual, some intervention, something that they can call their own and they can use in benefit of their communities. And then, the intervention should explicitly reflect the values, beliefs, and worldviews of NHPIs. And lastly, that relationships are key. I think we talked a lot about trust in these past presentations, and I think trust is built on relationships, right? So building relationships in the research process, but then also reflecting important relationships in the interventions that we generate and create. So I'm just going to end there. Thank you.
Thank you very much, Dr. Okamoto, for such a great presentation. And our third speaker today will be Dr. Marjorie Mao. And the title of her talk will be Intervention Research to Improve Health Equity, a Molelo. Go right ahead, Dr. Mao. Dr. Mao, you're muted.
That could have been a good thing.
We can hear you. Welcome.
I know. I was muted and I was like, maybe that's a good thing. Hey, Carlos, could you do me a favor and put the copy that I sent to you up?
Yes, Mark will take care of that momentarily.
Oh, okay.
There we go.
Aloha kako, everybody. Aloha, everybody. I have the pleasure and honor of actually being on this panel. What an awesome 2-day conference. And next. So I'm going to talk a little bit about cultural interventions, and I've had the privilege and kuleana of working in this field for over 30 years. And so I'm going to start off with a definition, because I think when you say cultural or culture, people may have a different sense of what that means. And if you Google this word, you will come up with a lot of different definitions. And this is the one that I selected, which is cultural of or pertaining to a particular culture, a noun. And the way culture is the way of life of a people, including their attitudes, values, beliefs, arts, and sciences, modes of perception, and habits of thought and activity. Whereas intervention, also a noun, in medicine, it can mean a number of things, including treatment, a procedure, or other action taken to prevent or treat disease or improve health in other ways. Next. So I'm going to share with you today briefly a mo'olelo, which is our story, our genealogy, and it's been a long and winding road. This is coming from my perspective, but there are many perspectives out there. I'm going to talk about the early years where our word in Native Hawaiian communities was kind of a word you said in a whisper. The middle years, which went from community place to community engaged intervention research, and what we have learned over the years, the we kako we. Next. So the early years, as Scott has also pointed out, and there's a small typo here, is in the 1990s, where health disparities among Native Hawaiians and Pacific peoples were known. I came home from the continental US in the early 1990s, and everybody knew it. Everybody in the Native Hawaiian and Pacific Islander community knew how sick and what the health statistics showed. And what they asked us were, what are we going to do about it to make it better? So I cite these two research projects that I have worked on personally. Back in 1992, the Native Hawaiian Health Research Project was the first population-based epidemiological study using standardized methodology to study cardiovascular disease and diabetes risk factors of Native Hawaiians 30 years of age and older. And at that time, we found an astounding prevalence, age standardized prevalence of 22.4%, and impaired glucose tolerance, because there wasn't the term of prediabetes at that time, of 15.6. And so we communicated to the Native Hawaiian community. That means 1 in 3 people either has diabetes or at high risk of developing diabetes. We then worked very closely with 2 communities on Hawaii Island and Kauai to conduct a quasi-experimental study that was culturally tailored. It used community peer educators trained by healthcare professionals, nurses primarily, and we found that the Ohana-supported intervention was better at lifestyle readiness to change than usual care, and it mediated health, diet, and physical activity behaviors. Next. At around the same time, the Diabetes Prevention Program, the landmark study showing that lifestyle prevents the onset or postpones the onset of type 2 diabetes was occurring. We also had the opportunity here in Hawaii to enroll Native Hawaiians and Pacific Islanders, and of the 3,000 participants, all of the Native Hawaiians and Pacific Islanders were actually recruited from the state of Hawaii. It was a total N of about 20 of 3,000. So you can imagine on the analysis side what that meant. But the study was, I think, ahead of its time because they were intentional on enrolling 50% of the 3,000 individuals enrolled in this randomized control trial to be of minority populations that were at high risk for developing diabetes. So there was an American Indian sites, and unfortunately they were close, but they only reached 45% of the DPP participants were non-white. And this study continues on today and has gone from a randomized control trial to disseminating the lifestyle by the CDC and American Diabetes Association into YMCAs, for example, and other communities. And we have been here in Hawaii, we've been part of the DPPOS 2, 3, and now 4. Next. I then want to skip over to some of the interventions that Dr. Kaholakula and myself and other communities, PIs and scientists have been a part of, called PILI, standing for Partnerships for Improving Lifestyle Intervention, PILI Ohana. And this was, I think, one of only a few types of RFAs that was looking at 11 years of funding. And I think that having sustained intent on growing, interventions and research over time, I think was really instrumental in this tremendous success of PILI and PILI Aina and PILI this and PILI that. I say that with some humor, but I think it was really instrumental and wonderful that NIMHD actually love this type of NOFO and RFA. Next. In addition to that, NHLBI also funded an opportunity to look at cardiovascular disease disparities. We were fortunate to get funded, and we had in partnership with the Queen's Hospital, and we had an intervention called Malama Pu'uvai, and it ran from 2004-2009 funding. Again, you'll see the same sort of progression to create qualitative studies with communities informing us, what should it look like, what should be involved and developed into the intervention, then an RCT, and then an adaptation to clinical practice. All of these included mixed methods approach, community engaged approach, clinical academic partnerships, cultural adaptation. Again, we went from cultural tailoring to cultural adaptation of an evidence-supported program, and the outcome hospitalization. Next. And then, of course, Keawe and Meleluk and a whole team of people from Kulanona Po'e undertook this tremendous study. The pilot study was actually measuring the energy expenditure of both modern and traditional hula. I highly recommend it. Maybe many of you already know of this, I think a milestone landmark study that actually looked at the cultural dance form of hula as a means to lower a cardiovascular risk factor, blood pressure. Keawe also and his team ran an RCT, and these are some of our participants in a celebration of that. But again, the same idea of, some background and developmental work on the metrics, and then an RCT, and then sharing it with our community. Next. So what have we learned working with Native Hawaiian and Pacific Islander communities? I do believe that community engagement is necessary in Native Hawaiian and Pacific Islander research. They help to prioritize the research question. They co-create and co-design with us. They're involved in the protocol development and implementation. They not only do enrollment and retention, but so much more. They help to translate and assist with the uptake of the intervention or the findings by Native Hawaiian Pacific Islander people. But I would also say that after all these years, while community engagement is necessary, it may be insufficient. We need so much more than just the community engaged. Next. So reflecting on our mo'olelo, I would have to say that culture in our research experience is critical for robust interventions in Native Hawaiian and Pacific Islander communities. Next. However, building culture into our health interventions means that we have to understand what shapes culture. Culture is shaped, and we saw this in plain view in COVID. Culture shapes what we define as a problem, how we respond to the problem, and who has the power. Next. And as I was thinking about in Pacific Islander and Native Hawaiian research that I've learned over the years, is that there needs to be a recognition, both, at a governmental level, a national level, a local level, of a distinct Native Hawaiian and Pacific Islander identity and cultural context. And I put this map here because it's amazing to me. All these brilliant scientists don't even know where these places exist. We need policy and advocacy of everybody, kako, aimed at growing our research, relevant research for our communities. In addition, we need sustained support of Native Hawaiian and Pacific Islander scientists at institutions with affirmative track records. And I think I've heard that over the last 2 days of this workshop. And I would concur with that based on our experience. I think today you heard about metrics for Native Hawaiian, Pacific Islander cultural context and worldview. And I think that was right on. I won't spend any more time on it. And I do believe this idea of Indigenous science needs to be recognized as robust and relevant, not just to this region of the Pacific, but to other populations and communities across Turtle Island. Next. So in a perfect world, this is sort of my summary slide. I would imagine an Indigenous health research ecosystem. So you can see community engagement plus. It's necessary, but there needs to be so much more. I envision knowing the culture, learn the culture if you don't know it. And I'm still learning the culture through the lens and worldview of Indigenous knowledge, or what I call ancestral knowledge systems. We need funding for Native Hawaiian and Pacific Islander scientists, both established and emerging, to grow and nurture the next generation of Indigenous science leaders. We need to transform research into a tool to achieve health equity that embraces, and we don't stop at health equity. It needs to embrace innovation and discovery, because we need to think about the future. There should be, or I would recommend, establish a program to include community in the NIH peer review process across all ICs. And the great thing about this idea, even though it seems sort of out of left field, there's actually an example at National Cancer Institute that already exists and has been in place for years, called the CARA program. And then critical reflection. Again, that's part of our ancestral knowledge system, where we would look at the ecosystem's performance on overall impact and effectiveness over time. And I'm hoping that this would create a space for Indigenous science. And that would be my perfect world. Next. So I'll stop there and end with this wise proverb about, if you want to go fast, go alone. If you want to go far, go together. And it's been a pleasure to go so far with so many different people over the years. So mahalo, maruru, namihi, and I'll stop there.
Thank you very much, Dr. Mao, for the insightful talk and for bringing all three presentations into a close. I will now turn it over to our moderator, Dr. Michael S. Spencer, who will introduce the discussants. Thank you.
Thank you so much, Carlos, and to all the speakers. As we enter this discussion section, what I'd like to do is first individually introduce each discussant, give that person an opportunity to make a couple of comments, and then go to the next discussant, and then we will have an opportunity to go back to the beginning and ask some questions. So let me introduce the first discussant. The first discussant is John Ray Taitano Jr. of Health Consultants Pacific. He is a native son of the island of Guam, husband and a wonderful wife and dad to two husband to a wonderful wife and a dad to two beautiful girls. He writes, "My efforts to advocate, support, and administer health care is to ensure our children have a better access to quality care, increase health subsidies for access to healthier food options, and greater push for preventative care. He has been in healthcare for over 15 years and has seen a massive increase in technology, research, and practice improvements. And he believes that closing the gap in minority health should be a key goal within the next 15 years. John Ray Taitano.
Hi, everybody. Thank you very much. This was a great presentation. I don't understand why my camera does not seem to be working right now. Of course, it was working a few minutes ago, and now it just died out. I will try to do my own tech support on my side to try to get that thing operational. I just had a great, I was able to work with Dr. Novotny on the CHILL program. So there are some things that I've done with her on PICA on Guam and in Pohnpei. So I look forward to these discussions.
Thank you so much. Next speaker is Filmar Mendoza Kabua. She currently serves as a nurse educator for the Office of Community Health and Research at the University of Arkansas for Medical Sciences. As Native, Asian, and Pacific Islander registered nurse, Ms. Mendoza Kabua is committed to enhancing cultural interventions and inclusivity across research and nursing education, community health advocacy, and evidence-based practices. Her mission is to significantly decrease mortality rates and enhance health outcomes among vulnerable and underserved NHPI communities, starting with the Northwest Arkansas, extending to other states and reaching as far as the Republic of the Marshall Islands. Filmar?
Yahweh Olive, it's an honor to be here. Thank you so much for inviting us. Motaka.
Thank you. And then finally, last but not least, Jane Chung-Do, Professor and Associate Chair at the Office of Public Health Studies at the University of Hawaii at Manoa, where she's had the privilege of collaborating with rural and Native Hawaiian communities for over 15 years. Her research focuses on supporting healthy eating habits in rural Native Hawaiian communities through a family-based backyard aquaponic program called Ma'alama, Mini Ahupua'a for lifestyle, and Me'ai through aquaponics. She also co-founded the Waimanalo Pono Research Hui, a grassroots group aiming to enhance community-driven and culturally grounded research and programming. Dr. Jane Chung-Do.
Aloha, everybody. Thank you for having me here. Just great to be in conversation with those who I consider to be my mentors and role models over the years. So I'm looking forward to this discussion. Thank you.
Thank you. I see you're back, John. You want to kick us off? Oh, I think you're on mute.
There we go. If it's not one thing, it's another, right? I know Dr. Novotny was talking about all the great work that CHILL has been doing across the region. One of the things that she did bring up was leadership, and I just wanted to know, was there similar characteristics in the or best practices of those leaders that you saw, so to try to to try to get the buy-in from the communities, knowing that there's different communities out there and everybody has their own cultural differences, although we're all islanders here. Was there anything that was similar through them?
Yeah, thank you. Thank you, John. Nice to see you. Half a day.
Half a day.
So kind of to back up a bit, we relied heavily on our local partner. Of course, we have the people at the Land Grant College there, Patty Coleman and others. Patty, who's been with CHIL actually for many, many years. I think I first met her like 20 years ago, to help us and to guide us. But in terms of if you're interested really in sort of traits that we observe, leadership takes many forms, and one of the things we identified was we actually ended up calling it role modeling, and this was a term that the communities chose because we found it again, it took so many shapes, and some of our role models were children. So think people who you wouldn't necessarily think to put the label of a leader on, a child who is interested in gardening and who we encourage them to show the other kids in the school about that, so we really found them in all kinds of places, but we had to look. And so we were guided initially, I would say, by the ideas. And then, that put another lens on it is where do we find people who are trying those ideas? So, somebody referred to snowball method. I mean, essentially it was that we asked one community member, and basically that community member would ask another community member and bring to the table a whole range of ideas of different kinds of role models that were doing something in that list of activities. And so they really did look quite different from one community to another. As you can imagine, we had Alaska along with our island communities. And so, for example, we had a clothing swap in Alaska for the winter clothing that was determined to be a critical thing to helping children get outside and be active and enjoy the out of doors. And that became an activity. But of course, that wasn't quite as pressing in a lot of the island communities. So I don't know if I answered your question, but those are the thoughts that came to my mind. I don't want to
no, I think that was great. I think it was just to reiterate that, each community is different, and even maybe within the community, there could be sub-communities that are very unique. So I just wanted to hear you just to, touch on that there would be some differences. Thank you.
Would any of the other panelists like to contribute to that question?
I will follow along with Tatiana's question to Dr. Novotny. So the question that came up is regarding the intervention strategies that you use in these jurisdictions. Are they adaptable to our NHPI across the United States?
Well, that's an interesting question. I mean, they were co-developed with these communities. So, I think the process, there's been a lot of discussion about kind of where do you start. I think no matter where you start, there needs to be a lot of back and forth. If you start with an idea that came from outside of the community needs to discuss it. And if you start with an idea that started in the community, it still may need to be discussed, in other venues for some of the implications, especially this kind of idea of trying it in another community. But I will say that even across the CHIL region, and of course we developed quite a lot of trust and relationship in the leaders of CHIL across the region, but people were inspired by each other and they would try ideas from another jurisdiction. So I would think that there could be at least a seed of something that another community, particularly that is starting from an NHPI cultural lens, could work with and could find interesting in another setting.
Thank you so much. Jane, would you like to ask a question?
Sure. Thank you again. One of the common themes that I saw across the three speakers and your projects and the various NHPI communities was the importance of relationships, and that long-term funding, long-term support is needed to build these partnerships. And the quote that Marjorie ended with, right, that we have to work together to go far, but that work takes time. So what do you think are ways that institutions like funders, universities can help and support emerging researchers to do the work that all three of you have achieved in your careers? What can other emerging researchers learn from, as well as how can institutions better support researchers to do this kind of work?
I'll jump in, Jane. So, I mean, it's tough because a lot of these grant mechanisms, they're 2-year, 3-year, 5-year. You have Clemma, suggested this in her earlier presentation, right? So it's like, you start the grant and you're already behind, and that's just, not even taking into consideration all these other things that we've been talking about in terms of the building of the relationships and things like that. So I know that in the past there were larger grants that were like 10 years that allowed you sort of a big chunk of time at the beginning to develop relationships. We don't have that as much anymore. I don't know if that's financially able to be revisited, but if not, I think that there have been some efforts to recognize that, but they're still kind of time limited. So, I think the whole REI series, the Racial Equity Initiative through NIH, has tried to build some of that in. But again, that's like, you have 1 year. So it's kind of like, I mean, they're recognizing it, but it's still kind of, it's a little insufficient still. So I think as a funded researcher, it's hard for us because we get stuff funded and then we're constantly thinking about the next one, right? Because, I think one of the things that, I was just having this discussion with someone in the community, which is you don't want to just get a 3-year grant funded and then be done. Because that actually ultimately could be more disruptive and do more harm than not doing anything at all, really. So, once you enter community and start getting research funded in community, you kind of have a responsibility to continue that work, right? So, Dr. Novotny's work, CHIL has been around for, I mean, you saw the series of years and years and years that she's been working on this project. And, that's why they're able to have these relationships and move that science forward. And, I think that it's a lot of work on our end, but I'm hoping that, there could be sort of a meeting in the middle, right? Where it's like, okay, we have to hustle and continue to try to get these grants to continue our work within the communities that we're collaborating with, but at the same time, recognition that from NIH, and in this case, NIMHD, that there needs to be something more on the front end that helps establish those relationships, particularly for newer investigators that are entering the space, right?
So if I could add on to what Scott was mentioning, Scott, I love what you said, because I kind of felt like, in the early part of my career, I was feeling like I was the only one person standing who wanted to do this kind of work, and it was so stressful. People who work in this way, well, I do it by choice, but it is stressful. So I wanted to actually step back a little bit and thinking about what would be really helpful and how do people get this kind of work done in other institutions across the US. And so what I wanted to suggest is that there needs to be some structural support for Native Hawaiian and Pacific Islander research and researchers and communities to be able to carry out this work for the right reason, for the betterment of the health of our populations. And there's a lot of noise in the US, as you know. There's all kinds of a dysfunctional Congress and all that kind of stuff. So amongst the din of that noise, I guess what I was thinking that NIH might be able to help us with is provide for an opportunity to build endowments into institutions that have a commitment to this research area. There's a lot of institutions around the United States, and how do you think they weather those, valleys of low funding? They have structural support within their systems that's built in that will carry you through, the next iteration of when you can compete. And it shouldn't just fall on the faculty. It shouldn't just fall on, one school. I think if you believe that diversity is going to result in the best science possible because of diversity in discipline, diversity in background, diversity in sex, gender identity, what have you, I think everyone would agree that increased diversity provides for the best opportunity for research discovery. Then I think, this idea, NIH at one time, NIMHD, in fact, created an endowment program. And I'm not exactly sure how Dr. Ruffin pulled that off, but I think it would be, it has been instrumental, I think, in other institutions and in some of the institutions that were able to compete successfully for those endowments. And I don't know if that's possible, but if you don't ask, you never know. So I'm just going to put that out there. Thank you.
Thank you. I want to go back to Phil Mart's question, because I think there's been a lot of sort of question about generalizability and how do we reach, other communities, and how do we include, different groups from throughout Pacifica. And, one of the questions I kind of had was, are there sort of core components of a cultural intervention that might be generalizable, or at least things that we might be able to anchor ourselves in that might work across communities? I'll give you a couple of examples. So when I was in Detroit, Michigan, I worked with Black and Latinos, and we had, for the Black group, we had hustle and step classes, Chicago step classes, and for the Latino community, we had salsa dance classes. We realized the group started wanting to go to the other people's class. So we started just having an event called Dance for Life, which included both of the groups, Another example is, I believe, I don't know this research as well as you all do, but I believe in the Kahola project in KKV, Kuakalihi Valley, there was Micronesian families that really enjoyed doing hula and learning hula as part of, even though it was the host culture as opposed to their own culture, they really resonated with that, so just putting it out there, are there common components that actually traverse our individual groups? Are there characteristics or components that all of us share as Pacifica people? Just putting it out there. Anyone can answer.
Well,
I could answer, but I'm going to let Rachel go first. Go ahead.
Oh, sorry. Sorry, Marjorie. We can tag team here. I'm clearly biased. Come from my degrees are in nutrition, but food we all eat. It's actually how I got into the field. Food as a basic need, and working with populations, actually at the time more with health problems related to undernutrition, and really more as all of the things around food. But certainly cultures are very attached to their food, and it's a great way to get introduced to a new culture by experiencing the food, especially as presented by Native people, so Indigenous people. So that's just top of mind to me.
I wanted to say that over the years, what you are talking about, Michael, is some of the reasons why it's so hard to get our work published. So I took note of your presentation, Scott, about finding just 14 papers on the topic of interest and using Prisma. But I can't tell you how many times I've been told by journals that said our audience would not find your article of interest, but nice try. And I'm paraphrasing that because, you know, nobody had ever met a Native Hawaiian or Pacific Islander that they are aware of, although we infiltrate the community, right? We're hidden in plain sight. But I guess this idea of generalizability is really important to the science. I think we all know that. And I would say that something that Rachel touched on, besides nutrition, was this idea that what are the common elements of the work that we do? And I think people from the continental US tend to think of us as island people, small little islands of X number of square miles. But if you ask Oceania people, they know that the ocean actually doesn't divide us, it unites us. And so we consider our homeland all of Oceania. I've heard the term Pacifica. I think that's just me trying to catch up with the cultural terms here, but you know, Oceania ties us together. And I think my first point in the ecosystem is that if you understand your culture, and everybody has a culture, so there's a Black and Hispanic culture. They love dance, so do we. Our dance forms are different. But I think if you step back from, you know, the trees and look a little bit at the forest, you can see that the forest has these characteristics that are generalizable to almost any population. My colleagues in Indian country and up in Alaska, they see us and they go, yeah, that's just like us, you know? And so I think there is, I think for us, at least for me, as you notice in my slides, I started on land and I ended up in the ocean, is that we bridge that. We're ocean people. I think somebody else said that as well earlier. And that unifies us. And we need to keep drawing off that wisdom. That's just my thought about it.
Can I just make a comment on Dr. Mao's what she just said? So I wasn't, she brought it up. So I'm gonna just extend off of it a little bit. You know, and Mike, I understand your question around core components and generalizability. However, just, you know, full honesty, and this is with both grant review and publication, is that I often feel, and this is just my perception, that that term has been sort of weaponized against our types of research, right? So it's like, so, you know, an example for grant review would be like, you need to sample the whole population. I'm like, that's, you know, what? You know, it's because, you know, it's small, so you just have to sample everybody, or which is ridiculous, or, you know, that whole thing around publication and generalizability. Well, this is a small population that lacks generalizability to the continent. Like, I've gotten that over and over, and not just me, a lot of my colleagues have gotten that as well through the Cancer Center. And, you know, we've kind of talked about this, you know, in our individual chats and, you know, behind closed doors around this kind of response, but it's quite, you know, I mean, I you know, based on, so I mentioned Dr. Mokawao and colleagues' piece in 2008, and I wrote a Viewpoints article to that piece about my experience around grants and publications. And, you know, I was kind of saying a little bit like, you know, it's a little ironic that, you know, we're in social work and we're supposed to be helping people, but then we're like marginalizing a whole population of people in terms of their needs and their science. And I mean, that doesn't really make a whole lot of sense. And is that really, are we really, you know, fulfilling the foundations of what our discipline is supposed to be fulfilling? So I see Mike nodding his head because Mike's a social worker. So I just, you know, I'm glad. I wasn't going to bring it up, Marjorie, but you brought it up, and so you got me going. So sorry.
Oh, no, I appreciate it. Thank you so much. And, you know, I just want to say Dr. Mokiao and I actually had a paper recently rejected because we were using data that was too old. And it was the NHIS, which is one of the few data sets out there that it's nationally representative, you know. There's nothing newer, you know, yet it was, you know, we were told that the data was old. And 2015 old.
That's a good point, Michael. If I can extend and ask to extrapolate further, because I think we're getting near addressing a critical point, and that is, so it's important to obtain input about cultural acceptability of research across the whole research enterprise. So what are some things to keep in mind to increase cultural awareness, cultural sensitivity, and value placed on NHPI research among reviewers, research partners, and non-NHPI communities when evaluating research done among NHPI communities? And so would the development of an IRB cultural resource guide be beneficial? So yeah, that would be great if you guys can provide your input.
I think Jane has something to say about that.
Yeah, I would say let the discussants chime in as well. Yeah, sure.
Jane, go for it.
Well, I also wanted to, I know we're running out of time, so I noticed that there are a lot of questions in the chat box. So should we refer to those first? I just noticed them. Okay, so we have a first question to expand on Dr. Chung Do's question. How can federally qualified health centers support NHPI research? Marjorie, do you want to take that since you've worked a lot with FQHC?
Well, I was going to say, how can research help FQHCs? Kind of the other way around, actually. I mean, we've done that to a certain extent. I think other people have done that as well. So I don't feel like I'm the expert, but I think that there should be co-benefits for being in the research space, and FQHCs have needs and serve an important population, and so they should have a voice and use that. I mean, I think it's not the other way around.
Anyone else? I do think that I do think they make outstanding partners, and you know, not only provide access to the populations we need, but also I think they're also nimble organizations that oftentimes can be creative. You know, I've worked with a lot of FQHCs, and what's useful about working with them is they also have access to different kinds of funding as well. So yeah, they're very useful organizations to work with.
I guess I would just generalize a bit more about approach. I guess thinking about our experience with the colleges and other partners, but in particular the colleges that I would imagine would translate to some degree to federally qualified health centers, and others goes back to that commitment to institution building and infrastructure building and capacity building in the broadest senses of really being community building and really being in it for the long haul and finding ways to change how we do things so that it gathers the data appropriately and with the community. And it's not tied to a grant cycle, but rather it's, you know, really changing the paradigm. So I think that's the goal. We've tried to keep that in mind really with every step. Realize that we're grant funded and, you know, what's going to be left. And so, and really checking our role, which one needs to do anyway, but when you're coming in with soft money, as has been said, you know, I think one has to be really clear about that and not wanting to do something that will leave a big hole when the money's over. So really working to build institutions. Some of our partners, some of the colleges, we had to get DUNS. I mean, we don't have DUNS numbers anymore, but it was a DUNS number because you know, they had never submitted a federal grant before. So we were doing very foundational institution building that I think has translated and partnered with the training, and we made a commitment to doing degree training so that it wasn't just training to get the work done, but it was really training for the future and for the potential for those individuals to go on and do their own great things. I'll stop there.
Your comments are related to another question in here, and that is, what is the role of the academic institution in building infrastructure towards engaging communities as well as Pacific Islanders and government?
All of the above. Okay.
Yeah.
I do mean all of the above. I think here in Hawaii, with the recognition of this place, Pa'aina, that they have an obligation, as most other places that have sacrificed their land to be part of this union called the United States. They, for the most part, have not lived up to what people think it should be. But, you know, our ancestors sacrificed for this land exchange, and there should be some reciprocity for that. So the institutions should include, in addition to hiring individuals that come from these places, because like Keawe said, you know, without Hawaiians, there is no, you know, you talk about, you know, these cultures, you can't have it without us. So in addition to hiring though, once you get them in, they need to be supported. And there are so many things about promotion, recognizing the work that's done in these understudied populations that could go a long way, that institutions would embed that in their system. So these are systemic issues that take a lot of work to reverse, but I think workshops like this that maybe provide a space, and for individuals like me who have been around for a long time, back in the, you know, more black hair days. This great background, yeah, because it makes me look like I don't have gray hair. But you know, I have seen some progress clearly, but there's so much more that needs to be done, and the next generation is actually calling people on the mat and saying, so, you know, let's recognize, you know, Indigenous people.
Yeah, and just to add to that, I think that the academic institutions need to recognize and incentivize mentorship more, right? It's not just students in a classroom sitting in rows with, for student credit hours, for what so I really feel like a large part of what we're trying to do as a community here is, build the NHPI investigator workforce, right? And we're not going to do that by just having them take, some class in classroom, right? It's working with us, getting mentored by folks that are in the field doing the research, and eventually having them take over our programs of research, because they're the next generation. You're not going to do that in a classroom. So that can help, right? You'll learn skills in the classroom, but ultimately you have to have them doing the work. And I feel like academic institutions don't explicitly incentivize mentorship of undergraduate, graduate, postdocs, and early career faculty. And a lot of us, it's important to us, so we do it, and we do as much of it as we can. But a lot of us are doing it around. In some of our universities, teaching 4 classes a semester. That's kind of crazy. So I think that would be a good first step.
Hi, can I make a comment?
Yes, please.
I'm a PhD student myself. This is my first year. And I noticed that as a future generation researcher, there's not a lot of outreach or encouragement to the minority communities about these amazing works that are available and who to contact and who can we reach out for mentorship. Fortunately, I have Dr. Rick Lung and Dr. Pearl McKillfish as my mentors, and I am very privileged and honored to have them support me. However, considering about my peers in Hawaii, about my peers in Washington and different states, how can we empower the future generation researchers to reach out to all of you amazing researchers who have already paved the way for us to reach out to you, and what are the gaps that you all see right now that we can start from where we're at and advocate for it. And going off of that also, there's a question that I wanted to ask: how do you suggest researchers record cultural influences? Because everything about us Pacific Islanders or Pacifica or Native Hawaiians, we're so into our cultures, and we are a very unique population. And how do we suggest researchers record cultural influence in data collection in a manner that allow translation on those interventions to different cultures? Or do you believe it would be more beneficial that each intervention start with the culture first and build its way outward?
Anyone would like to comment?
Well, so I see we have a minute left, so I'll just make a quick comment. So to that last point. So, in 2014, our team sort of introduced this concept. It's not even a model. It was kind of said in passing on one of our articles about what we call the adaptational bridge. So what we were arguing is that one of the things that, feedback we were getting for our work is that it's like, yeah, that's great, but that takes a lot of time and resources, and you can't do that for every single population. So that's not a sustainable approach from, an NIH perspective, at least, because there's not endless amounts of money that they can fund for every single population. So one of the things I was thinking about is, well, there needs to be adaptation, but the bridge to that adaptation shouldn't be huge, right? So we shouldn't be taking, you know, a parenting program for African-American families in the South and trying to adapt it to Native Hawaiians in Hawaii. That bridge is enormous, both culturally and geographically. So, so it's kind of like, how do we, you know, and what I argued, or what we argued at that time, was that we don't, and still, right to this date, we don't have enough of a scientific foundation for interventional research with NHPIs. So we need to invest in grounded interventions, because we have to develop that in order to have something to adapt to, right? That's close, right? So some of our work, for example, I mean, they're trying to adapt some of it into Guam, and that makes a little bit more sense than taking something from, you know, Georgia for African-American families and trying to adapt it to Guam, right? So, so I don't know, that sort of, I don't know if that addresses what you were asking, but.
Thank you so much. Well, I would just want to say thank you so much to all of our discussants and to our panelists for this engaging discussion. There's still more that we can probably, you know, there's plenty more to talk about. I know that in the question and answers, there was a little bit of question about what can NIH do to help empower and build capacity in our communities as well, and as well as continued discussion around how do we build our literature base if we can't get into Western publications. So, I mean, these are remaining questions that maybe, you know, if we want to use this for our final wrap up, we can also sort of roll into that. But I'll stop here and I'll turn the floor back over to our leaders here and go on into the next section.
Well, Mike, thank you so much again for moderating, and to you, Carlos, for helping with this as well. I wanted to thank again the speakers for the fourth session and discussants, but actually, and also to all the speakers and discussants, and for all the questions that have been provided. It's been very fruitful, and one can see that we could really spend a lot of time on this, but you know, our time is limited, and so I want to move to our well, at least maybe the slide's not necessarily accurate in terms of the wrap up and conclusion, but more about our final session, about this, our final panel. I do want to invite, you know, as we're talking, I invite all the speakers and discussants who are still here that have participated in this to turn on your videos as well. And I believe we've, you know, we've heard the call in terms of only be able to ask questions or directly messaging it to individuals. So I believe Mark Gifford, if you could be able to open, at least have that chat open. I welcome people to, oh, thank you. I welcome people in the audience to please feel free to add in comments and questions and everything. Kiawe, I don't know if you wish to lead off, because I think what would be helpful is to provide just a very brief summary. And it's very challenging, so don't feel like you have to cover an entire dissertation's worth or more and then some, but of what has been presented and discussed in brief. And then, you know, again, I think what I'd like to do after you're done is, again, share that our key meeting questions and what we're hoping to accomplish from this. So please, Kiawe, Bowings.
Mahalo, I'll be happy to get us started. And I welcome Mike, as well as everyone, our NIH colleagues, to chime in if I do miss anything. And thank you to Mark and others who were able to put everything together really fast for me to share with all of you. So to kind of summarize the last 2 days and what we've been hearing, first, let me start. There were three recurring themes, if we look at thematic areas that were emerging across the different sessions and discussions. And one of them was around these health disparities and social determinants. The discussion that we heard emphasized social, and I would add cultural determinants, such as education, income, and living conditions affecting NHPI health outcomes. Again, I would also add that we heard a lot about cultural factors that are important to our people that also affect our health and well-being, whether they are considered risk factors or protective factors, mediators or moderators, that these things are very, very important. Understanding these factors historically is crucial for designing effective interventions that go beyond clinical solutions to also include social and policy changes. Wouldn't it be great that we not only get great clinical outcomes from our studies, but also great social, cultural, and social determinants of health outcomes? as a result as well. The other theme that emerged was around, again, the cultural context, even geographical context in many cases, because we talked about how spread out our populations are across the United States and across the Pacific, as well as the methodologies. The emphasis on cultural knowledge highlights the gap in current research methodologies that often overlook the unique cultural context of our communities. We heard a lot about culturally tailored methodologies. Helps to ensure better participant engagement, also lead to interventions. But I actually want to modify this because I'm reading off the notes. We heard a difference between culturally tailored versus culturally grounded, and that more recently, a lot of investigators in our communities are moving to culturally grounded interventions, drawing from the strengths, the natural strengths built into our cultures, our communities, and leveraging that for health promotion. And that was clearly heard with the group we just heard from in this session. The other recurring theme that came up was community engagement and collaboration. It is just not a good thing to do, it's a necessary thing to do in our work. The importance of this, and rooted in the principles that health interventions should be co-created in communities, with communities to ensure they are relevant, accepted, supported, and sustainable. And that's a key word here. Two keywords: acceptable from a cultural and a community standpoint, but sustainable. This approach fosters trust and enhances the impact of health programs. And we also heard that it's necessary to increase participation in clinical trials and other research. So the gaps we heard also gravitates around certain themes. We heard about data disaggregation, even cohort aging as an issue. The lack of disaggregated data for NHPI populations, of course, we all know this, limits the accuracy of the health assessments and interventions, making us causal inferences about our interventions because of aggregation with other populations, but even aggregation within the NHPI, because we are, again, diverse communities with different health risk factors and statuses, different aspirations. We saw that with COVID when we started to disaggregate the Pacific Islander communities, for example. Many people talked about the aging multi-cohort, the MEC study, as you heard yesterday, highlighting the challenge of using an aging cohort to address current health questions. And I think, Mike, you touched on this in your conversations you were just having, that you were gigged for having outdated citations, but sometimes that's all we got. So we need to definitely get some work done around this area to be more current in our in the state of science. And this suggests that the need for new consortia to manage ethnic diversity and sample size issues moving forward, so that we just don't do the same old thing as aggregating, but we do something different that's meaningful to our communities. The upshot: accurate disaggregated data are essential for tailoring health solutions and policies to NHPI communities. Again, an aging cohort may not reflect the current health status of social determinants affecting our populations. Aggregating data also with that of Asian populations, for example, is problematic and does a disservice to both large ethnic racial groups. This is well documented, but the practice still continues. Despite the OMB Directive 15 defining us as a separate racial ethnic group, it still continues. This needs to stop. Further, although progress has been made for data presently being collected, and past data aggregation practices still remain a challenge, as I mentioned. The other thematic gap area is around social determinants of health measures, because we all know now, in order for us to address health equity issues, we have to go upstream. As Dr. Mokuwal pointed out earlier yesterday, we have to go upstream and look at the factors that really contribute to our health and well-being. If we continue to go downstream, all we're doing is doing disease management, perhaps, rather than disease prevention. Dr. Park noted that the MEC's limitations in addressing individual level measures of social determinants of health, which could be informative for understanding health disparities. So we need to take a look at these measures and what are we really measuring. And as we heard earlier from Mr. Chang, the great example of household related income, for example, not taking into account that we have multi-generational families, will inflate our socioeconomic status and make us look perhaps better off than we actually are. The upshot, the ability to collect and analyze data on social determinants at an individual level would provide deeper insights into factors contributing to health disparities among NHPI populations. The other thematic area around gaps, small-scale studies, chronic disease linkages we talked about. While small-scale studies offer detailed insights, as Dr. Park mentioned, the challenge of linking these studies to chronic disease endpoints due to small sample size can be problematic. Upshot, enhancing the scale and scope of studies could improve our understanding of the links between social determinants, cultural factors, and chronic diseases in NHPI populations. Another area of gap, upstream factors in early life adversity. I touched on this a bit earlier. As Dr. Mahaber highlighted, a gap in understanding upstream factors such as early life adversity that influences health outcomes in HPI populations. We know from research, adverse childhood events are the greatest among our communities, and it does increase our risk for adulthood diseases, both mental and physical. Upshot, research on early life adversities, long-term impacts on health could lead to more effective interventions targeting the root causes of health disparities in our communities. And finally, the other thematic gap area, if you will, is around biological differences in disease risk. And we heard a lot yesterday from Dr. Mauna Kea, for example, and in his work revealing that NHPI populations exhibit biological distinctions that impact disease development in response to treatment. And he articulated well the underlying epigenetic processes that are occurring, the interaction between genes and environment. This includes variability in microbiome and accelerated biological aging among Native Hawaiian Pacific Islanders compared to other ethnic groups. The upshot here is recognizing and understanding these biological differences are crucial for developing tailored interventions and preventing disease more effectively in our NHPI communities. And I end this summary, and then I ask others to jump in case I've missed anything and enhance this. But there are opportunities that we also identified. Enhanced data collection analyses is one area. There was a strong call for improved methods of data disaggregation and analysis specific to NHPI populations to inform more effective health policies and practices. For example, developing culturally relevant data collection tools. Dr. Lanaka Opo and Dr. Suresh Tamanong work on the Hili Nutty model was an example shared by Dr. Okamoto as a cultural safety framework. Underscores the necessity of creating data collection tools that are culturally relevant and sensitive. This model advocates engaging communities on their terms to advance self-determination and preservation of NHPI values and traditions. And I want to just add here that NHPIs, we aspire to maintain our cultural connections, our cultural values, our language, and so forth as Pacifica people. The traditional assimilation model that often is applied to other populations does not apply to us. So we need to look at these factors, issues around self-determination and preservation of our culture, because they are important. The other thing is community reports and data warehouses came up as a point of topic and opportunity. Initiatives like the Papakolea data warehouse that you heard from Ms. Puni Kikoha, spearheaded by community organizations such as Kulonana Poe, exemplify how local data collection and management can empower communities, providing valuable insights into social determinants of health and enabling us to be more targeted in our interventions. The upshot, we need to invest in the development and implementation of data collection tools that are culturally relevant and sensitive to the NHPI communities, and sensitive to the diversity of NHPI communities, if I may add. This includes supporting initiatives such as community data warehouses that are managed by and for NHPI communities. Support for research and community interventions was also an area of opportunity. Increased investment in NHPI health research and community-based interventions was strongly recommended by many, including the development of culturally sensitive healthcare services. In this area, building community capacity was also discussed. The emphasis on nurturing meaningful community participation in research and enhancing community research capacity highlights the importance of equipping communities with the skills and resources to conduct and contribute to health research. This requires training, as highlighted earlier, but also creating equitable partnerships where community organizations are actively involved in the research process. Upshot, we need to increase support for community organizations to build their research capacity, including providing resources for training, mentorship, and partnership development. This will empower communities to lead and contribute to research that directly impacts their health and well-being. The other area, leveraging community-driven models, examples like the Biggest Loser competition and other culturally tailored interventions demonstrate the effectiveness of community-driven models in engaging NHPI communities and addressing health disparities. These models, rooted in community needs and cultural practices, offer a blueprint for expanding health interventions with NHPI populations. The upshot, we should encourage the scaling of successful community-driven health interventions by providing funding and resources and support for these initiatives. This approach should prioritize interventions that are grounded in NHPI cultural practices and values and have demonstrated success in improving health outcomes. The other area for opportunity is around policy and structural changes. Opportunities for addressing structural factors through policy changes and community support were highlighted, emphasizing the role of cultural practices in promoting health with NHPI communities. Again, addressing structural inequities. Discussion on the need for policy changes often centered around addressing structural inequities that impact NHPI health, such as land sovereignty, water rights, and access to sacred places. Recognizing the intrinsic link between land, culture, and health with NHPI communities, as Dr. Mapuana Antonio also articulated, is crucial for developing policies that support health and well-being. Improving healthcare system partnerships. The call for investing in healthcare system partnerships and clinician engagement points to the need for policies that facilitate better integration of culturally competent care with existing healthcare frameworks. This includes recognizing and supporting the role of community health workers and leveraging traditional Hawaiian and Pacific Islander values in care. We should advocate for policy changes that address the structural determinants of health for NHPI communities, focusing on land rights, cultural preservation, and equitable access to healthcare resources. Policy should also aim to improve the healthcare system partnerships to ensure culturally competent care is available and accessible to our communities. I end now with 5 specific recommendations that have been provided to us to address specific scientific gaps. The first one is establish new cohorts and consortia, develop new diverse cohorts and consortia that can provide comprehensive disaggregate data on NHPI populations to address current and future health research needs. The second, incorporate measures of social determinants, enhance data collecting efforts to include individual level of measures of social determinants of health, utilizing innovative methodologies that respect NHPI cultural context. Although I heard a lot, we have a lot here about individual level, but we also heard about family and community level measures as well, because we are a collectivistic community. Number 3, around recommendations, expand scale of studies, increase the scale of studies to improve the linkage between detailed cultural and social determinants data and chronic disease endpoints, enabling the development of targeted interventions and sustainable interventions, most of all. The 4th is research of upstream factors. Invest in research focused on understanding the impact of upstream factors such as early life adversity, the historical stressors, on health outcomes in our communities. 5th, and finally, tailor interventions. It says here to biological differences, but also to our cultural and specific geographical differences, because we are a diverse group of NHPIs. Utilize insights into the biological and behavioral differences and disease risk specific to NHPI populations to develop culturally and biologically tailored health interventions. With that, mahalo to all of you for this very productive last 2 days, excellent presentations. And right now I ask if I had missed anything, please add from my NIH colleagues and Dr. Michael Spencer.
So I wanted to, Kiabe, thank you so much for summarizing all of that. That was wonderful. And you said, as you're saying, and I feel the final, I'm thinking, no, I'm sure there are more too. It's just the ones that are kind of like on virtual paper. But I'm just sharing the screen again because I wanted to again share that there were a number of key questions for this meeting that I opened us up with, about what are the known gaps in our knowledge of the causes and contributors to NHPI health and health disparities, and what are these challenges and opportunities.
Gabriel, we see the other document on gaps and data disaggregation.
Sorry, I apologize. I thought I was sharing the right screen. Do you see this one, my slide?
Yes.
Oh, my apologies. This was what I was intending to show. Thank you. And then, you know, what are the unique strategies, tools, and data sets that are necessary to conduct NHPI health research, and how can we best address these scientific and research challenges? And I point this up because I wanted to just ask again, you know, amidst of all that we've discussed and presented, amidst what Kelly and Mike were helping to moderate and summarize, is there other things that, you know, that need to be highlighted specifically, or is there anything missing? And, you know, I bring this up because, you know, there's all this calls for, you know, new course and consortia, and I can, as an example, you know, and the incorporation of the measurements of social determinants. And in some ways, we're moving that, and I'm sure many of you are doing that in some of your areas of research, and when you're working with your respective communities. But I wanted to ask, was there anything in addition to this? And I welcome those who've presented, who spoke, and even members of the public who are still with us right now. And, you know, because like I know, like one thing that was, I remember one example that was brought up very briefly, but by I believe the speaker, but not touched upon, you know, was like, we didn't hear too much about issues of climate change, you know, about when we talked about the environment, but, you know, about the climate change. And, you know, there was a recent report about the exposure of the Maui wildfires. And I believe there are some members here in this meeting who contributed to this preliminary report that was just released last week about the exposures and some of the inherent risk for that. But I think there are many of us, not only within the NIH, but throughout many areas that recognize the growing recognition and importance of climate change and its impact on health. And then we did talk a lot about traditional practices, but I hope we can talk a little bit more whether there's other aspects of it, whether there's health or resiliency. And, you know, there's, again, even from the chat, we were asked to connect with other partners, not just community partners and organizations, but other federal agencies. And I'm hearing that in many conversations, even outside of this meeting, about how it's important for us to connect with our other federal agency partners, such as the USDA. So in any case, I want to just stop briefly, and then I'll just stop sharing because I really want to see all of you and ask for your feedback.
Gabe, if I could, can you guys hear me? Okay. I just have a very simple, you said, what is missing and what more? So I think, you know, this is a very simple ask, I think, which is, I think NIH coming back to this group, an expanded group who couldn't be here today, and giving us some updates of what's going on, because, you know, everybody put in a lot of effort to make this workshop, you know, really highlight what the current state of the art and science is, but, you know, what happens to it, you know, and I think some kind of report back. It's kind of like what we talked about in our research, that you can't just go in and then say, okay, we're done, funding ended. So I think some kind of report back would be refreshing. And it doesn't have to be really complicated, but I think that dialogue is important to keep us inspired and moving forward and in touch with those, you know, all these topics. So anyway.
And I see Dr. Mokwal. Thank you, Dr. Ma, for mentioning. I think Dr. Mokwal wants to echo what you just said, perhaps.
I do. I've had a text mail conversation with Calvi earlier on this, Marjorie, and it's, you know, there's been an investment of researchers and community collaborators in this workshop, and everything they have said is so valuable. And so it's capturing that in some form that is disseminated. When we look at community-based participatory research, everything is about doing good work, starting with the community at the beginning, but disseminating at the end, so that we all share in this growth of information and knowledge, and we know and participate in its next steps. So thank you, Marjorie, for starting me on that, and thank you, Calvi, and others for listening to me for a long time. Aloha.
Mahalo. Dr. Raphael, I see your hand up.
I mean, thanks for organizing an incredible session over the last couple of days. We have a lot of talent on this call, and we are positioned throughout the US. And I really feel like the consortium idea is really crucial, I think, to advancing NHPI health across, Hawaii, the Pacific, the US. And if we can come together and be partners, executing various types of projects throughout the US, I think we could be really impactful. And I do want to say that there's the Asian American and Native Hawaiian Pacific Islander cohort study. It's an aggregated study. We really need one just for us and across the US. And I hope that there's some interest to create opportunities for consortium to exist across geographies so that we can all do amazing work together. Because there's so many good people on this call doing diverse work, and we could build something very powerful and train the next generation of researchers through a model like that. So thank you.
Are there others in the audience who, whether through the chat or if you wish to raise your hands, please, by all means, chime in. One thing I wanted to add, Marjorie, the aspect of dissemination, as I've been hearing, and I've been hearing through in multiple ways, was the importance of sharing and communication and having this bidirectional feedback. And one thing that we were planning on even before going into this, what we plan to do is we plan to write as one example, write a brief report about this workshop and publish that, and we plan to share that. And I think it would be very responsive and hopefully open in the sense that that's our plan, is to share that with you, the audience, those of you who registered, and also perhaps, if we possible, publish that on our webpage as well, as one example of dissemination.
Can I say something?
Sure.
I just wanted to say, because I'm looking in the chat here about this new cohort that has been funded by NHLBI and multiple ICs across NIH. For me, this is like an opportunity of a lifetime. I started out with the Native Hawaiian Health Research Project, which I thought was going to be a future cohort study, and it wasn't. It was done in an excellent way using, I think, some of the best tools at the time. So it is a study of 10,000 Asian Americans, Native Hawaiians, and Pacific Islanders. And I think something that would be beneficial to come out of this collective group is to know that we are part of that. Hawaii is one of 5 sites. The other sites are in California, Pennsylvania, Illinois, and New York. And those are not the places I would normally think of to find my family of Native Hawaiians and Pacific Islanders, but that's the way it is. And so we want to take advantage of this opportunity because it is, it could be, a once in a lifetime opportunity. And so I would like to invite all of you to help us make this a really impactful cohort study. We work diligently to help educate some of the other investigators that were awarded on this NOFO to understand who we are. We're not immigrants. We are from here. And thanks to my colleague Alika Mauna Kea and Lonnie Park and the team, we try to respectfully, but unapologetically inform people of many of the discussions and chat words that have been shared today. We don't apologize for those kind of stances, but there's a lot of people that still don't understand that our worldview, our cultural context, and it's going to take some ho'omau, perseverance to make it into the future. So I welcome you. We're working on our new webpage for the Pono Health Legacy Study. It is one of the five recruitment sites for this 10,000 cohort. And mahalo Kalani for agreeing to be part of our OSMB.
Margie, I want to jump on this because it's an important topic you're bringing up. And I think it speaks to why the recommendations we're putting forth is so important. An example of this is we're doing a cohort study with a very diverse group of people, first of all. But as we learn, there's so much diversity, but yet there's got to be standardization, harmonization of the metrics and so forth. And it is a concern, right, for all of us. I know Marjorie, you and I have had discussions because as many of you pointed out, there are unique social and cultural factors we need to measure for which we don't have measures yet. And existing measures are probably not valid and inadequate. And many of our speakers pointed that out, one with the dementia example, that we may, everybody may have dementia because none of these measures were normed on our people. So we may be selecting people for which don't need an intervention or erroneously concluding that there's a high prevalence of dementia. So, I think, Margie, you would agree 2,000 of the 10,000 for the diversity of NHPI communities is still inadequate. And I would say that at some point, we need to develop better measures, conceptual models to help guide a cohort study that will allow us to increase the numbers so that we can have within subgroup analyses in a meaningful way to highlight specific health inequities, their risk and protective factors across a diverse group of NHPIs. So anyway, Dr. Lai, I want to make sure that we also get other thoughts on this before, because I think we have 5 or 10 minutes left, probably.
Yeah, we've approximately just under 10 minutes before we should probably properly close. But I, again, appreciate that comment, Kiave, about the need for a further evaluation of certain specific social determinants of health and probably consideration of those, for example, those socio-ecological frameworks in mind. But I mean, this is the purpose for this meeting, this discussion, and I wanted to see,
Can I just say one thing about, so one of the things we've come to realize after all these years, and we finally have an opportunity to get our toe in the door to create a cohort for us, is that you have to embrace heterogeneity when you talk about Native Hawaiian Pacific Islanders, as well as Asian American populations. They have an incredible diverse, but you have to embrace that. And the fact that NIH recognizes that these are understudied but important populations in the US defines this idea. So we cannot just use old and validated instruments validated in other populations and just apply them to this heterogeneous group, because by definition, all we're going to get is what we already can predict. We don't have to do the study if that's what we want to do, because this is our opportunity actually to help shape that paradigm. But it's not easy, but we're doing our best. And I think when we join our voice with some of the information, data, and new studies and young investigators here, I'm delighted. I'm thrilled. I look forward to the future with a group like this. But by definition, you cannot. I mean, because why are they understudied? Because nobody's had the right for a lot of different reasons. But you can't just use validated instruments, as Kiara was mentioning, and just expect that we're going to find something different. No, we're going to find the same thing we did before. So
Mahalo nui
Yeah.
for that strong plea for better research and including the diversity, make sure we consider diversity of our groups. I also see a lot of our other speakers, discussants, we have 5 minutes, well, actually less than 5 minutes. We have 3 minutes left, and we want to be sure, that we captured fairly your contributions, your thoughts in the summary that I gave and what Dr. Lai also elaborated on and what others already elaborated on as well, to make sure we capture that. This is an important time for us as NHPI to get into this document, as Dr. Lai mentioned, will be put together a report and made available. This is a huge opportunity. So if we missed anything or we need to emphasize it.
How are you?
Yeah, Fillmore.
In the workshop.
Aloha, Fillmore. Mahalo. But if you want to jump, but anyway, others, anything that we need to add, highlight, emphasize?
Joey.
Yeah, Joey.
Hey, folks. Yeah, thank you again for the opportunity and just speaking from a community point of view. Very humbled to be here. I'd just like to encourage both institutes and researchers to just reconsider their approach to dissemination. Instead of allocating budgets for traditional methods like printing flyers and things of that nature, embrace technology. Let's effectively share the remarkable work that you folks all do. And as Island City is, we would be more than happy to help assist in producing videos and things of that nature to help share. And if anyone wants to come on air and do an interview and talk about the incredible work that you do, we invite that as well. So thank you with that. I
want to add to that. I want to suggest that perhaps when the report comes out, there could be something on your radio show around this to advertise in our communities, to generate some interest and thought and conversation around it. Is that possible?
Absolutely, 100% from our end. And that's the reason we created the only Pacifica radio station, is to really fill that gap and share all the incredible work that you folks do. So, yes.
Mahalo for all you do.
Thank you.
Any others? I'm going to call out my fellow NMHD, Dr. Rena Doss, if there's any other thoughts, because I know she's been very gracious and being quiet, but I know she has a lot to share and I know she's very passionate about this as well.
Thank you, Gabe, and thank you, Kiawe. I think you guys have summarized everything, and we just wanted to hear any last-minute thoughts on the research areas that NIMHD could enhance that we haven't thought about, because we really want to hear from all of you who are the experts. So how NIH can help promote research in these areas. And that's where this workshop has been so helpful. So if you have any other thoughts later on that didn't come to your mind right now, please feel free to send it to us. We would appreciate that. Thank you.
As a nephrologist, I have to say that kidney disease needs to be studied in the NHPI population. It's awful. So that's my plug for kidney disease, and hopefully get some interest from NIDDK as well. Thank you.
Thank you, Kalani. I'm sure Ray would also agree.
Should we move into closing summary?
Yes, I'll I don't know, Gavin, if you wanted to start this off, and I can close it up.
I'll turn it to Mike.
Yeah, no, thank you so much. I've been thinking a lot here, and of course, there's a lot of thoughts going through my head, and I think what this really kind of what it kind of boils down to me is that we need to build momentum off of this and continue to do as I think Dr. Mao suggested, and be together on this for the long haul. I see so many gaps. I think about I've been thinking more and more about, the dissemination side, but also even, we started off this workshop, I think, with some news about the lack of NHPI researchers and the lack of NHPI PIs on NIH grants. And, it makes me think about not just about how do we develop new researchers to come, to come up the pipeline, but are there things within our review process? Are there things within the grant process that we may not be capturing the work that we want? I know, for example, that, oftentimes I'm sitting in a study section and I'm definitely, I know I don't see you all in the same study sections. You're probably alone in your study section too, that we're often the only ones. And, if we get an NHPI application, you'll get it, but then probably the other person, the second reviewer will get it is probably not an HPI. And it's just really kind of hard being the one representative for, an entire population that doesn't see your work, doesn't see this population as being as important or as relevant, and so I feel like there's some biases in the entire processes that probably favor people who are much more in line with Western methodologies, Western, epistemologies and such, and so I don't know if that I know we can't change overnight, but I think that there are things that we can do that could mitigate that sooner than later.
Anything you'd like to add?
Yeah, no, I just want to echo what Mike said, and it has been such an honor and pleasure to really be a part of this, what is a historical event, I think, for all of us as NHPI. For a long time, we've been fighting for about data disaggregation. We've been saying how we're invisible. We talked about data genocide, borrowing that term from our American Indians, Alaska Native colleagues. And for a long time, we've been struggling to get any kind of attention from federal agencies and from others. And COVID came along. Unfortunate situation for all of us, the entire world. But one thing it did do was it united Native Hawaiian and Pacific Islanders. It developed the capacity to address health inequities in our communities. But it also allowed us, gave us the podium from which we could push the issues that we needed to push to be heard around data disaggregation, the need for more attention, and that we have to do things different for our populations. So I mahalo all the speakers, all of the discussants. Mike and I, along with our NIH colleagues, spent hours going through, and it was tough because there's so much great people. We wanted to make sure there was a balance between NH, Native Hawaiians, and specific Pacific Islander groups, and so that all voices could be heard and elevated. We wanted to make sure it wasn't Hawaii-centric, although we recognize a lot of the research is happening in Hawaii, out of the University of Hawaii, as mentioned earlier in presentations, but we wanted to make sure there was balance. We wanted to have strong community representation, and mahalo to our NIH colleagues for ensuring that we had keynotes from the community. Something that I've not experienced in other NIH workshops. So I commend NIH, NIMHD specifically for this. Too many people to mention, all wonderful. And I'm hopeful, and everyone's asking about a report, making sure there's follow through, making sure that what we have shared here turns into actionable items for us. And I think Mike and I would both agree that that is something that he and I, along with our NIMHD colleagues, want to ensure. So I think I can speak for Mike. We'll make a commitment to following up and staying connected. They've been great to work with, and I think there is sincerity in what is being asked and what is going to be done. I know I've had many conversations. Fortunately, I had a great opportunity to be with Rena at Dr. Doss at a recent conference and had a time to just chat with her. And Dr. Gabriel Lai has been great, also pushing for this and making sure this was done right. I'll stop there and let you say the final words. Dr. Lai, I know we're going to close this as we open it with a cultural protocol, but you have the final words, my friend.
Thank you so much, Calvin. Thank you so much, Mike. I want to thank everybody, and I truly mean that, everybody here who is present, for those, even for those who aren't or not able to join us for the second day, or left a little bit earlier today, and just really convey my appreciation, my gratitude for all that you've done, you've been doing, for participating and for speaking. This has been humbling for me, and I also hopefully speak with some gratitude and my my appreciation for all of you. I said earlier that this is not something that this is done on a solo effort. I want to really acknowledge everybody on the planning committee. I want to acknowledge all the moderators. So I want to thank Aruna, for Angela, for Carlos, for Addie, for serving as moderators for your respective sessions. I want to thank our note takers, Tu and Karen and Montessa, other members of the planning committee, including Dr. Rena Das, Samdat Mahavir, and everybody has been so crucial and so important. I especially want to highlight Montessa, who's been in the background because she's a fellow with us in our at NMHD, and she's really been kind of like that key backbone piece. So I want to kind of acknowledge her and thank her for all that she's done. I want to thank Rena for her support and her guidance in the conduct of this workshop. I think her support and her being conduct, and also we've invited our IC director, Dr. Asaf Prestabo. He really is passionate about this, and I think without his support, this wouldn't have been possible. And so I just want to again remind you all that our intent is to write something, to have some type of report to disseminate, to share. And as someone did question, but I hope that you want to be clear, this is not a one-off, that this is a continuing conversation, and that there will be further conversations. And I'm hearing all the wonderful chatter and seeing the chatter on the chat. And if people want this to be a little more frequent, then let's see what we can do about that. Okay. And I think with that, I will now pass the final closing to you, Calvi and Mike.
I just wanted to take a minute to acknowledge all the help we got from Sidem and Mark Gifford and his team.
And yes, sorry, Mark, thank you. You and your team. Without this, we'd be floundering. Thank you, Mark.
And with that, we close like we open, recognizing our ancestors and recognizing our shared connections. I offer this Oli or chant composed by Tapuri Tangaro. Really speaks, it's an inspiration chant, talks about call upon the powers that be. We ask for the heavens to open up and bring forth the rain that is necessary for growth as we plant that seed that eventually turns into a sprout, into a bud, into a leaf, a branch, until it becomes a strong tree that cannot be toppled over. And I offer this for everything that was shared, all the lessons learned, and the actions we will take going forward. It's like a tree. We plant these ideas, we nurture those ideas, and we see it to fruition. So with that, mahalo. E ke ako nui aku I ke ako aloha ako poko. Vehe kalani, vehea. Kau hola kalani, kau hola ia. Vavahi a kalani, vavaia. E kulani hako I kau maila I luna e hu. Aua maila ua kupu maila kupu amu o maila mu o aliko maila liko alau maila lau alala maila lala akumu maila akumu paahina ole ho'olumai e ho'olumai a ulumai la e a hele o vale no e. Mahalo.
Mahalo.
Thank you again.